Good morning, everyone. Thank you for joining us on this auspicious day where I hope this is one of many that we welcome you to Africa. We're going to please use the hashtag IACRN21, IACRN21, to let people on Twitter know that we are live and they can join us. So a couple of housekeeping rules. We might have people who are making a bit of a noise, so we will deal with that, as well as you might be muted. If you're muted, we will unmute you, but feel free to put some comments in the chat box. We're going to start with a presentation by Liz. Thank you so much, Liz. She is in Switzerland. She will tell us more about where she are and what her study is about. It's about case study of pediatric research in remote settings in the DRC. I'm going to stop sharing, Liz, and then you can share your slides. You just need to unmute yourself as well.
So good morning, everyone. Really delighted to be together here today. So I'm going to do my best. I'm just going to put my presentation so you can see it. Brilliant. So as Elise said, my name is Liz. I'm the head of clinical operations at the Swiss TPH. So I'm based in Switzerland, but actually I spend most of my time in Africa. I will give you a little bit of an introduction about Swiss TPH and what we do and why we're working in Africa.
Liz,
yes.
On my side, I'm seeing your background. I'm not sure whether that's for everyone. I don't see your slides.
We don't.
Can you see my slides?
No.
Oh, we didn't. We just saw the back, your screen, your computer screen.
Can you see my slides now?
Yes. There you go. Thank you.
Brilliant. Okay, beautiful. Okay, great. So, yes, so without losing much more time, I just wanted to say thank you for everyone to be listening to this presentation today, where I will try to do my best to give you an introduction to doing clinical research in the DR Congo. I work for the Swiss Tropical and Public Health Institute, and the really mission statement for our institute is to improve health globally. But we do really work with people locally, nationally, as well as globally. But the aim really is to take really this concept of taking science to the bedside, from innovation to validation. So we are known to have worked a lot with sleeping sickness, where some of the drugs were actually discovered in our preclinical lab, all the way to actually having formulation that you could use in the field, as well as working quite a bit on malaria. So today's presentation is actually about one of those malaria studies, whereby the drug Coartem was actually discovered in our preclinical area, so in our innovation labs, and actually was thereafter taken over by Novartis and MMV, and now we are at this in validation and application stage of really getting enough evidence so that it's working in the field as we hope it should. So just a bit of background of who am I, because a lot of people probably do not know me. So I'm the head of the clinical operations unit. I had a team of about 15 core people, but we really work globally. I'm a PICU nurse from background, so I worked in the UK for quite a bit, but actually I was born in Cameroon and raised in Chad. So I've lived most of my life in Africa, and this is where I went to school. And it's only when I decided to move to university that I was fortunate enough to go to Europe and to go to England to train. I've been working for over 15 years in clinical research, so I have quite a bit of clinical research expertise. And at the moment, the type of studies that we work really is, although it's got a global coverage, is really with an emphasis in Africa, which is why Elise asked me to talk about some of the work that we do. We have quite a bit of FDA and sponsor audit experience. So we have, from a regulatory point of view, quite a lot of experience in that side of work. And we're also doing a lot of work in terms of facilitating clinical research in terms of capacity building for the WHO, as well as supporting PPI for refugees. So there's a strong emphasis at the moment on refugees and supporting them, and we do quite a bit of PPI work in that area as well. So in terms of our clinical operations unit, one of the things to remember is in Africa, we have quite a very young population. So most of the countries have, 50% of their population is usually under 30. And depending where you're working, the life expectancy will be very different. And so just to highlight that in terms of diseases area where we work at the moment, we've got quite a range of diseases area where we work. So in South Africa, we work primarily on TB and HIV. We also work in Lesotho, for example. We work across in malaria, and we're working in over 13 countries on COVID studies at the moment. But we also work on other areas such as hypertension and helminths, of course, which is really important. So in terms of phases, although 30% of our portfolio is pediatric focused, we have a wide range of phases that we cover as well. So this is where we are operationally at the moment working. And just to give you an idea as to why I was chosen for the DRC. So as you can see in the map, this is the DRC, this is Africa. So we work in all of these countries at the moment. And on the map in the DRC, we actually have an office, which is why we are working very closely in the DR Congo. So this will be very familiar to quite a lot of you. This is the field. If you go to Tanzania, for example, in South Africa, you have very good setup, but this can be very different where you're working. So the closer you work in sort of areas where there's sort of much more conflict and much harder situation, this is what the field looks like. So this is in Chad, doing lumbar puncture on the field to try to make sure that we can get research going for sleeping sickness, arriving in the DRC because we need to do monitoring. As well as trying to get, when it's a rainy season, to the sites to be able to make sure that things are happening as they should do. One of the things that we do is to set up everything from the hospital setup, the lab setup, etc., which is one of the things I'm going to be sharing with you today. One of the things as well maybe to remember is that in terms of research development in Africa, things are very tricky. A lot of people like to come to Africa because manpower is cheaper, it's cheaper to do studies, but often we have to remember this is an aerial view of Cape Town. Often the drugs are being targeted for people on the right-hand side who can actually afford to buy the drug. And one of the things that myself in our unit work on is really to work on the left-hand side, where we really have people who are really in need of having medicines and formulation that work for them. In terms of capacity building, just to highlight that so that in case you have any questions about that, so we do support the WHO for their fellowships in making sure that we have nurses as well as doctors that come and learn how to do clinical research with us. One of the highlights for me has been really Lesotho. Lesotho is a country that is run primarily by nurses, and 1 out of 4 patients is HIV positive. And the nurses there are absolutely amazing. So we've been doing a lot of work with Lesotho, with the nurses, in terms of supporting them and having this monitoring and quality capacity building. And then also work for the IACRN, trying to increase GCP, especially in Rwanda or in areas where we have a lot of conflict and where we're doing quite a lot of work on schizophrenia. So now, that was just the background. So just now we're going to plunge into this study, and I just would like to introduce you to DR Congo. Just a couple of facts, because I think it's quite important when you talk about Africa. A lot of people think about Africa, as you well know, as a big country, when actually it's a huge continent. The DR Congo is the 2nd largest country in the continent. It has 4 climatic regions. Is cut by the equator, so depending where you are, you will have a very different type of weather and different issues. It's a really vast country with immense economic resources. So if you have a smartphone, you have somehow somewhere been involved with the DRC, because this is where most of the metals and required for making smartphones come from. There are in this country over 200 languages, major languages being French, Lingala, Kiswahili, Kikongo, and Chibuluba. And so having to do research in this context where you have so many languages, you also have to think about pragmatically how you can facilitate good understanding, good informed consent, etc. It's also the 19th most populated country in the world. And the life expectancy of men is about 58 years and women 61. And that will become important in my talk about children in a minute. I also wanted to give you some basic facts about malaria. So malaria is a preventable and curable disease. It's primarily transmitted by female mosquitoes. And one of the things about malaria is that 90% of the malaria cases worldwide and 90% of the deaths worldwide occurred in the African region. So we have 13 countries, mainly sub-Saharan Africa, that is accounting for 76% of malaria cases globally, and also 75% of deaths globally. So it's a really important issue. It's preventable, and the main problem about malaria especially is that it has a huge economic and social cost, not only because you get so sick, but also because the sicker you are, the less able you are, the less likely you are going to be as a child going to be able to go to school and actually be of support into the family if as an adult you catch the disease. But most people actually catch it repeatedly. These 5 parasite species actually cause malaria in humans, and the 2 greatest threats are really falciparum and vivax. And falciparum is responsible for 90% of the deaths globally of malaria, and it's the most prevalent malaria parasite on the African continent, while vivax is also the dominant malaria parasite in most countries outside of sub-Saharan Africa. So making that difference is important when we look at working with that disease. In terms of pediatric focus, because I would like to introduce you to this pediatric study, is just to highlight that malaria is the leading cause of death in children. The most vulnerable group are children who are less than 5 years of age, and it accounts to about 61% of all malaria deaths. Neonates are often treated with undercommended dose of antimalarial, including quinine. So in the DRC, this is a really big problem because the DR Congo, is one of the major producers of quinine. So they are very unlikely to be using other drugs, the other formulation, because they want to be using their own drugs. So they want to use quinine. And of course, in neonatal formulation, in research, we know that about between 70 to 80% of the drugs in those populations are usually not being tested, which is why there's so much work happening in pediatrics to have appropriate formulation. But in this particular case of malaria, it's really important because, as I'll introduce you in a minute, the kids are really, really small, and so you can have overdoses very quickly. The combination products as what is the recommended therapy normally is so Coatem, which is the drug that this study was about as a case study, is a dispersible tablet. It's got a combination of artemether and lumefantrine. It works differently as a combination of 2 antimalarial agents, one that reduces the parasite and the other one is a bit more long-term, so that you have this ongoing release of antimalarial action over the next 3 to 4 days. But the problem with this dispersible tablet is that it had not really it's not being provided in a formulation for neonates, infants, and we know that quite a lot of neonates are actually catching malaria at birth, are catching them from their mother, or very early on, as sort of 3 to 4 weeks after they've been born, where they have less immunity from their mother. And so really having this better formulation where it's really required in neonates. If you look at the DR Congo and you look at the pediatric population in malaria, so we have, in terms of population, 41% of the population is under the age of 15. Okay, and this is really important when it comes to consenting and being a nurse in this environment. And it's also the second highest number of malaria cases and death globally is actually in the DR Congo in pediatrics. Malaria is the main cause of morbidity and mortality in the country, and it's accounted for 40% of all the outpatient visits, and 90% of deaths among children under the age of 5 are attributed to malaria as well. So we were approached by the funder, which is EDCTP, and the sponsor, Novartis, to do this study called the Kalina study. It's a multi-center, open-label, single-arm study. And the idea was to evaluate PK, safety, tolerability, and efficacy of Coartem, so this new antimetal lumenfantrine dispersible tablet, and really looking at Plasmodium falciparum malaria. So there's already three big elements. One is to do a PK study in a very difficult situation, to have children that are less than 5 kilos, and also have been diagnosed with falciparum malaria. So the countries involved are the DR Congo, Burkina Faso, Nigeria, Kenya, and Mali. And so we were approached because most of the countries were above the equator. And so during rainy season over there, the DRC would have had a dry season. And so when it's dry season on the other countries, we have rainy season and hopefully more cases, because those children are very difficult to recruit. So this is the DR Congo, and this is the capital is Kinshasa. And we located the site about 150 kilometers away from Kinshasa, so we have good access for blood sampling and shipping blood samples. And this is the site. It's in Kisantu, and it's the Hôpital de Saint-Luc at Kisantu. And I actually did the feasibility of this for this study. So I went to the hospital. It's a regional hospital. I was really impressed because first of all, they had an A&E. They could do blood transfusion, they had surgery, they had internet access and electricity, which is probably not what most people think about when they're assessing sites in other countries. And they had a neonatal unit with beds and nurses actually who were trained as pediatric. I was super impressed. They even had a play specialist. And the staff also training was also supported by the European partners, which meant that there was some ongoing mentorship and support for the staff. The pediatric wing had 84 beds with 4,450 admissions per month. So just to kind of bring you now to this reality of the clinical need versus the research needs. And when we looked at the numbers, we knew that they had quite a lot of cases under the age of 5 with uncomplicated malaria, with severe malaria. There are about 5,614 less than 5 years of age over the last 3 years that had come to hospital, have been hospitalized with severe malaria. So it was a good site. And we thought, okay, this will be the best site to go there, because you could not do the study in Kinshasa or in a bigger town, because there's a lot more public health and much better resources in prevention, which is fantastic. The work from the WHO there has been done very well, but this is a bit more remote, although reachable, and clearly that health prevention had not reached that area yet, and measures were needed to treat babies. So the site was a very good site, but in terms of research expertise, they had absolutely no research expertise. So, they had never done a clinical trial, and they had one doctor who speaks English, and they had one pharmacist for pediatrics for the whole hospital, and they had a minimal team of clinical nurses, and they needed a total lab setup. So they never had blood gases or anything like that. So taking bloods and making sure that you can actually check how the child is doing and what you're doing next, they just go by clinical picture. But they were very willing. They had malaria cases, and they were close to the capital, so we could actually ship the samples, and the lab samples transfer was possible, and we could actually support them from our unit that is based in the DRC, which is why I introduced at the beginning that side of what we do. So in terms of the pre-study start, in terms of full support required, we had to go through everything. We had to do everything with them, from R&D, ethics, regulatory submission, putting the SOPs in place. We had facilities we actually had to build. We had to put the machines in. We had to get in air conditioner to make sure that there was temperature control and we could cool things. We had to set up the pharmacy with the access. We had to set up the storage for the TMF so they would not be attacked by termites. We had to make sure that the site knew how to do a site budget and teach them how to do that, to make sure that people would be paid, because otherwise it was being diluted into the hospital and not actually getting to the staff who were actually doing the job. We needed to make sure we had internet. We actually have 3 internet providers at the moment to make it work. Electricity backup, which requires putting in place a generator and a laptop. So you can imagine, in terms of infrastructure, to put into all of that in place to make this study happen, there's a lot of investment required and a lot of talking that is required with the sponsor, the funders, to make sure that these things are in place, because these are things that they expect to be available in, you know, in countries that are not dealing with the same sort of situation. In terms of team training, we had to train everyone and teach them English. I mean, we are all French speakers in the team as well, but we had to make sure that they could communicate in English with the sponsor, because that was really important for an SAE and EAE's point of view, and they could communicate with the other countries. They had to be trained, of course, on GCP, on the protocol, and they had to have a full training from the lab in terms of reading malaria slides, because we realized that actually the lab was not able to do this really, really well. Which was really important in terms of diagnosing the children. So this is how the recruitment happens. You know, we had the hospitals I introduced you, and then we have, you know, 8 centers peripherally, where this is where you go there. So, you know, just to give you an impression, if you want to have healthcare coverage, so if you want to have an insurance, there is a support from the hospital for people to do that. It costs $8 and most people per month, and most people can't afford it. I think that most people earn, to have a delivery in the Centre de Santé, so in the dispensary here, you'd probably pay about $6 for your delivery, and most people can't afford that. So in terms of where we're talking in terms of poverty, we are really talking at an income of about $3 to $4 per month. A majority of the young women are all under the age of 18. There's a lot of ethical issues in terms of women who are too young to have babies, so a lot of postnatal traumatic work and reconstructive surgery that needs to happen. But these are the centers that actually see the patient. This is where the babies are referred when they are unwell, when they have malaria. And from these 8 centers, they are then referred to the hospital. So the babies, the way it works in terms of patient flow is the babies present to the center. If they are clinically indicated that they have malaria and they do a rapid testing, if they're positive and they meet the inclusion criteria, then the center calls the PI. And the PI then talks to the parents verbally, and if the parents are happy and willing to consent and to come to the hospital, the baby and the family are then transferred to the hospital. So I showed you earlier a little bit the roads that we have. The roads are quite difficult, so we are very careful about the centers that we chose, because the babies, when they are referred to the hospital, they're not choked by, you know, by the amount of dust on the road. So the centers are quite close to the hospital. They're probably about 15 minutes away maximum from the hospital, so that the baby arrives in a good condition and we are not stressing the babies by the time they arrive to the hospital. And then we repeat the malaria test when they arrive in hospital, and we clinically assess them. And if the babies are positive, then, and the parents are willing to consent, and we redo the whole consenting process, then the child is enrolled onto the study. The challenges that we have faced in setting up these studies are many, so from this whole setup of the project, but in terms of staffing and staff availability, as you can see clinically, there's a lot of work and that happens. They have crazy days. They have sometimes they see over 150 children per day who are really, really sick. So, you know, just to give you an idea about the babies that we have, all the babies that we have had so far in the study all required a blood transfusion upon arrival, because they all had a hemoglobin less than 6, because they are so sick. And so staff ability is a problem. The understanding of the study, because they are so used of working in a clinical setting and being really reactive in emergency mode, they don't really, the whole concept of research and putting your head around research and why evidence-based is really important is something they have to learn, of course. So they have this massive knowledge and learning curve to do, as well as learning English, because the sponsors refuse to put everything in French. It's more difficult for them from a pharmacovigilance to have everything in French, so the sites have to learn English. And also EDC, for example, electronic data capture, when you don't have internet, is super slow and it's super frustrating. So you can have a delay in terms of reporting safety events. So working around that to make sure that there's no delay and babies are being referred, and from a pharmacovigilance point of view, everything is done properly, is quite a challenge. And then, of course, you have this whole issue of delegation. You have the PI that speaks English, and then who does he delegate to make sure that the work is happening while he's being called into surgery or for delivery and all sorts of things. In terms of GCP, learn the whole communication, the issues about, advertisement, how you speak, how you communicate to parents, how you do the informed consent. The doctors knows what's best. So, why are you asking me my consent? You should just tell me what I need to do. So working around what consent is and reporting things is a learning curve, a very big one for them. In terms of recruitment, planning the recruitment, making sure they understand that, looking at communication, looking at consort. So in terms of clinical research, often we have the protocol, we follow that, but also looking at consort. So how many babies were referred, how many did you actually enroll on the study? How are you going to publish the results of this study later? How do you make sure you had good oversight? It's something they all had to learn as well. And we had a very big challenge, which is the parents refusing to be transferred. So you would say to yourself, but why? You have a whole team that will take care of this child now. They'll be in hospital, they'll be fed, etc. But the reality is that for most people this is why I highlighted how much people earn. For people who are really, really poor, you only go to the hospital when you're about to die, and there's nothing else. So actually having that stigma of being with the hospital, look, this is the place where you die, or this is where everyone has seen family members dying, because they always arrive at the hospital often too late, and so the situation is really bad, and usually most patients cannot make it. They have this sort of understanding of the hospital that when you go to the hospital, things must be really, really bad, and my baby is about to die. So the parents are refusing to be transferred there. But it is the only place where we have the capacity and the infrastructure to be able to support this PK study. And so having to work with the parents to make them understand that actually they're going to go to the hospital, but they're not going there because the baby is about to die, has been one of the biggest challenges we've had to work with. In terms of the IMP, the storage, the receipt, the dispensing, when you have one pharmacist, and the compliance with that has been quite challenging. Then, of course, I talked to you about internet during a randomization with IVRS. When you have, declines in electricity, or internet is not always working, is also can be a real challenge. And again, like I had said, the oversight of the pharmacovigilance side and reporting the SAEs, reporting them correctly, documenting them is really important. When you have, situation where there is a lot of fear of witchcraft and things like that, putting that in language where it is understandable by European countries who are looking at this in a way that pharmacovigilance is being reported properly is really, can be a bit of a challenge in terms of communication at the beginning, just to establish really that trust that we are not going to come down on them with a ton of bricks, but really supporting that. In terms of clinical challenges, babies always, as I said, needed blood transfusion upon arrival because they were so sick. And this poses challenges, ethical challenges for myself and the team as well, because you're giving them a blood transfusion because they're so sick. That they will, they've agreed to take part in the study and to be consented, but then we have to do the PK/PD, and there's quite a lot of blood samples to be taken. So really managing that from a clinical perspective is really a challenge and important. In terms of ethical consent and clinical oversight of these mothers who are less than 16 years of age. So one of the things about Coartem, about this drug and this formulation, is that the mom needs to breastfeed and the baby needs to have a full feed before they receive the actual IMP. And so what is tricky here is to make sure that you have this combination of very good nursing care and maternity support, so that the mom is able to breastfeed, is not so stressed, so that the mom and the baby has got that holistic care around them and are being well looked after. And so having that high tech then for the parents versus the clinical routine work has been challenging as well for the families, as well as the nurses and the doctors. And one of the things that we noticed that for us is really challenging is that the protocol allows, so you have the WHO growth charts and you have the lowest percentile, and the majority of our babies are lower than the lower percentile because they are so malnourished, and because actually no one has done growth charts in those countries. So we are working with protocols that are not actually reflective of the situation in those countries. And so that's an extra challenge in terms of science as to how we deal with that, and how we make sure that we are actually supporting clinical research in an environment where the formulation is going to be used in neonates, but actually the weights are not meeting what we are testing for. So just working with the sponsor on those elements are really important. And also the availability of the PI with these very long clinics have been quite important. The other major problems we have faced is the lab. So there's no engineers, and with COVID, there has been no supplies. Everything has been taken by the first world. So in terms of having the reagents to be able to work there, we have a 9-month waiting list, and the reagents only last for a certain amount of time, or they have an expiry date of about 3 months. So having that supply, making sure there's 2 engineers in the whole country to be able to check this machine and validate them. So, you know, when the machine breaks, to get the engineer to come and verify it, because we have one baby coming who's got, you know, really low blood sugar and very low hemoglobin, to make sure things are working is tricky, having those lab technicians. And then this kind of leads to inaccurate readings. And then you have that kind of, okay, from a research perspective, you need to have all of these parameters fulfilled, but on the other side, from a clinical perspective, you need to make sure you are very good clinically and making sure that you're not just relying on the machine. And if you have staff who have never really used those machines, you can have really a big gap between understanding what's available on paper and what's actually the clinical picture, and how you deal with that from a safety point of view and an adverse event point of view. And then the third challenge is that understanding of sponsors, of not understanding the local situation. They have no grasp of the challenges because they are not used to that. They don't understand why it got so expensive to actually put all of these things in place to make sure that GCP is adhered to, you know, and to make sure that we actually have high standards. And it's all about KPIs. And actually you ask yourself, can KPIs actually work in this environment? In terms of nursing, the local challenges, I just wanted to highlight is in those countries, a nurse is a nurse practitioner. So you have the doctor, and the doctor is usually the surgeon, and then the nurse is usually the doctor in terms of the, you know, their responsibilities, because there's just not enough staff. There's a lack of evidence-based research mindset. So we work with really in that area. It depends whether you have support, where there is capacity for support, etc. So in terms of putting in place then, you know, research competencies, when you have to also work the clinical competencies, it's difficult sometimes. You have a lot of staff shortages, of course, and staff are not being paid. So really making sure that staff are being paid, otherwise they turn up, they work very, very hard, but they're hardly being paid. You know, they earn less than $50 per month. Which is much better than the rest of the population, so it's good, but it's not enough to be able to survive often. So balancing the clinical research and clinical duties can be really tricky for the nurses. So I just wanted, in conclusion, to say that we actually recruited 5 of the 9 participants have been recruited in cohort 1. 3 of them were from the DRC, the other 2 were from Burkina Faso, and they've been treated. And conducting research in these type of settings where the formulation drug is targeted for is actually really essential, because otherwise we will be producing formulation that will not work for the population it's meant to be helping. And so it's really important that we do research in those countries, but and in those settings in particular. But it still remains a huge operational challenge. And so making sure that we have that clinical support as well as the research support is really important. So establishing research nursing where basic clinical nursing staff shortages are still prevalent is going to take time. It's happening, but it's going to take time. And so I'd just like to thank you for listening, and I'll be very happy to take any questions if you have any.
Thank you so much, Liz. This was formidable. I just want to read one comment that Jen just put in to say, let me just get to it. I feel quite emotional and embarrassed by what we have here, meaning in the UK. Liz is such a wonderful speaker.
Thank you.
Totally agree to that. Such power in your honest presentation, and may I add, without drama and making stories out of it, but just giving the real facts. It's overwhelming reality, and it's beautiful. That sums it up. Thank you so much. It's really a tour in what research is about in Africa. There are a couple of questions. The first was from John Gordon. He says, I might have missed it, but are there any practical ethical issues that you need to highlight or that you highlighted in terms of consent for underage or under 16 years old? So do you want to answer that question first?
Yeah, no, that's a really good question. So thank you for that. It's really tricky. So it also depends on legislation in the country. So girls under 16 years of age cannot make decisions for themselves. They need to be 18. So often, actually, the tricky bit here, which is difficult, is most of those children are being born out of, unfortunately, rape. And so we have an ethical question and the ethical dilemma there in terms of consenting. And then we have the other dilemma as to they can't consent for their baby. So you need to have like the whole family structure around it. So usually we obtain the consent as a consenting process in several steps, but we do a lot of conversation between the doctor, the nurse, as well as the partner if he's available, and but mainly the family, the parents that are there with the mom to make sure that we discuss this properly in terms of proving that. Yes.
Gordon, do you want to unmute yourself?
Yes, thank you very much, Liz. I mean, absolutely. And the more that I kind of see how consent is conducted around the world, I see that it's really a Western construct, the way that it's set up, you know, so that in Taiwan and China, and your example there, the idea that you wouldn't involve the family in consent is just bizarre. So I think it's really interesting to see how the way that the infrastructure for research has been established, how that applies in different countries, because it's not consistent, and it shouldn't be consistent because it needs to reflect the local need. Because if you were just to take consent from the individual, then that might not fit the context that you're working in the country you're in as well. So thank you.
No, thank you, Gordon. I think you also, you know, as you say, it depends on the context. If we also have an illiterate population, but they're very, you know, they're very mature. I mean, so you have what you'd have in the UK, the Fraser competency. I mean, it does not apply in research, but certainly it's you have this mom who have these children, and they have to make day-to-day decision. They have to take a decision between the 5 kids that have got malaria, which one is the most urgent one to take to the hospital. So they take their baby to the hospital, which is another massive ethical dilemma that they are facing on a daily basis. And who they're going to treat and who they're not going to feed, you know. And then in terms of obtaining consent, there is also having that verbal conversation, because they, you know, you give them a consent form and they may not be able to read and understand, but they understand very well the dilemma and what's required and so on. So having a process that works for the country is really important. So we do that as well. Of course, it has to be approved by the ethics committee. So we do that in conjunction with the community. We do, although it's not named as such, but we do actually a lot of PPI. So we do a lot of consultation with the local groups and the local, whether it's the church leaders or whether it is the, you know, the local imam or the community, depending on the setting. We do a lot of kind of conversation with the local community, the important people, to make sure that everything has been addressed.
I can't convey. I mean, it's just fabulous the work you're doing, Liz, and really, really want to commend you for that, because I mean, it's such an important thing to be doing. Really, really is. And as a kind of last point, I just think it's bizarre that there's not enough flexibility in the system to allow studies to be conducted in French. Because why does everything need to be in English all the time? It just doesn't. I just don't understand it.
No, I think you know, it's interesting. I think the thing is, at the end of the day, we need to have that common language. So it's okay. Actually, you know, most people speak 5 or 6 languages. So learning English, we found, has been the easy thing. They've all learned English. They've been fantastic. From the monitors to the lab people to the doctors. I mean, that's what we do. We have 7:30 during the pandemic last year, 7:30 coffee together on Zoom to try to learn English before we attack the protocol, you know. So that's the thing. But thank you for that. I think what I find very difficult personally, if you ask me, is that we have this really huge need and this huge pediatric population that has a medical need. And that's kind of in the terms of research and research, how do you say, R&D development, that a lot of the drugs are aimed at populations that can afford them, but not really always for the most needy. And then we want to do research with KPIs. And then we want to make it sure that it's, you know, there's not enough funding. At the moment, for example, we've seen a massive decrease of funding for malaria and TB and HIV studies. And we have people who are having to make decisions at the moment whether they're going to eat today or take their medicines, because, you know, the situation is so dire, especially with COVID. And we are trying to do clinical research, and there's less money for it. And there's a really big gap, a huge disparity gap between what's required on the ground and doing research and evidence-based practice, and what's actually available and understanding in terms of funding for this type of study to meet the quality standards.
Yeah, thank you. Thank you.
Thank you, Gordon. So I had a question, and maybe you implied that in your presentation, Liz. The question is the nurses that's involved in the research. So they are, of course, they're not clinical research nurses trained. They've never been on that. Are they employed by the research organization, by yourselves, or by the hospital or government, or how does that work?
That's a good question. So we use the clinical nurses that are there, and then alongside that, we of course, they get this, how do you say, they get this exposure to clinical research, and they learn about PK and PD and sampling and so forth, and the importance of following a protocol. But what we do is that for every patient that has been recruited, we are controlling ourselves the budget allocation, so that is not on the hospital responsibility, and just to make sure that the people that do the work are actually being paid, because this is the big problem. They do a lot of work and then they don't get paid, or get being taken by the administration of the hospital. So we have a two-way of contracting here. We pay the hospital so that they have their share because we're using their infrastructure, but we also pay the staff that are working on the study. And for every participant that has recruited well and has followed the protocol and everything has been done as it should be within the protocol, then they also get at the end the bonus payment for that, just to make sure that the quality standards are being met. So there's a bit of, it's not a financial incentive that we are forcing people to do it in our way, and that, you know, there's preference given to the research patient, but just an incentive that they're also motivated that they get something. And the best thing you could give them is not so much at the moment education, because we are doing that already, but just to have that extra financial support, because we also see that in rainy seasons they also have to tend to their fields. So it may be that they need to go in and work on the field, so that they have, you know, a bit of how do you say, of yield at the end of the rainy season to sustain their family for the rest of the year. So you have different situations, you know, it's not that you're being employed and you're going to be paid every month, and it depends also what's happening politically. So that's how we've done it.
It sounds like you have a performance allocated funding, or performance, it depends on performance. Yeah,
that's correct.
Yeah. So you say the capacity building is happening in any case. So is capacity building also towards clinical research nurses or nursing?
Yes, absolutely. So just the fact that they have to learn how a protocol works, they have to learn how to do PK samples and allocate it and support the lab, because there's only 2 lab technicians for the whole hospital to make sure that this happens, and things are being put in the freezer on time and so forth. So this is already an exposure to clinical research in many ways. And then also the fact that they're learning about evidence-based practice, because, you know, the country has, of course, wanting to use quinine because this is what they produce. So there's a strong emphasis, but also having sort of, in terms of evidence-based practice, kind of that education about, you know, how we treat babies who are really severely sick with malaria, and how we make sure that actually having an accurate diagnostics of malaria is really important. So you know which medication to give it, just the basics that we actually take time to make sure that this happens is also part of the process and the capacity building that happens.
Is it, I've got one more question. Is there anybody else that's got a question? No. So my question is, so what happens to when the research is done, what happens to the staff that they have the capacity, or do you move from research project to the next one? Or do they just go back well, I shouldn't say just go back. Are they then continuing with the clinical practice?
That's a good question. So I think it very much depends on funding, because we are also funding dependent. So we as a tropical public health institute, unlike a lot of the other public and tropical health institute, we don't get funding, we don't get core funding. So it's very much depending on the project we get asked to work on. So, but usually what we do is when we set up an infrastructure like that, we would like to come back. So we never do things on a short-term basis. We always work with long-term capacity. So we train, and what we try to do is to allow for the staff, like the doctor who's now learned English and has been a PI and who has learned to be a PI, because that's the in-par, capacity building that is happening. Yeah. Is to see whether we can continue that. Maybe there may be an exchange to go to another hospitals, or to actually take on more work in terms of studies, or actually be able to receive a grant to be able to go and study or continue that education as well. So there's that part that goes on as well. And so of course, when we have set up a hospital like that, what we also do is we don't usually give funding, huge amount of funding to the hospital itself, but what we say is that we leave the infrastructure. So when we leave, you will have the lab set up, and you will have freezers, and you will have the machine. And what we have to be careful about is that the machines we choose, the consumables are not so expensive, so that they can maintain that, they can continue using that. So that is actually sustainable. Yeah. I don't know if that answers your questions, but that's what we try.
That does. Thank you. That really does. Have got anybody else got a question?
I think there's a question from Javier Maga.
Can you read it?
Despite a hindrance,
do you to unmute? Javier, do you want? There we go. Javier, do you want to ask?
Hi. Hi. Good morning. First of all, thank you very much. It's very interesting to hear, all the hindrances that you guys come across that we just give for granted here. But I've recently moved to research, and I come from a clinical background. So I understand, there's a lot of hindrances associated with, going to the hospital. But do you believe that, there's a growing perception that research participants are receiving an improved care because of this?
Yes, I do actually. And I'll tell you why I do is that actually there is never capacity to follow up those babies. And what we do with those babies is we are reporting back to the WHO about those growth charts, for example, that malnutrition issues. So we will be reporting we are reporting directly back to Novartis, who's the sponsor, but also to the WHO indirectly. And then what we also do in this study, which would never happen in clinical practice, is that those babies are followed up to 1 year of age, which means they have the development assessment, which never happens. Normally, is that you come, you get treated, you survive, great. But no one has actually done this long-term development. So I think from that point of view, the babies get followed better. And because the study is, is put in such a way that we actually take into account growth and long-term outcome of those babies, there is that follow-up, which indirectly the babies will benefit from, which they would not have done so if it had just been routine clinical care.
Yeah, thank you very much.
Thank you.
Thank you for that question. I think if there's one more question,
I just wanted to say thank you. I've stopped crying, so I can say thank you.
Thank you, Jenny.
Well, from my side, I'm taking it there's no more questions. My thank you to you is actually setting the scene or the tone for the day, because most of the aspects that you presented to us in happening in real life and experienced by a real person, we're going to address for the rest of the day. So I thank you for this presentation and giving the overview of what clinical research and clinical research nursing is in Africa. although it's one country, but most of that is similar to what we experience in the rest of Africa, in my experience. So what I'm going to do now is I'm going to share with you what is Africa, or who is Africa, and a few research organizations, I'm saying here in Africa, but mostly in South Africa and one other country. So Africa has got 54 countries, and we've just visited Congo, but there's also, we're going to visit Ghana, Nigeria, Uganda, Kenya, Tanzania, and of course, South Africa. And with a population of 1.3 billion or more than 1.3 billion, so soon we will be 1.5 billion. Africa has got 5 sub-regions: Northern, Western, Central, Eastern, and then Southern Africa. And yes, I'm glad you used the word huge, Liz, because I was going to say the size of Africa is huge. We easily fit in the USA, there's Europe, India, there's a space for the UK here in Madagascar, we can fit in Spain, France, Germany, Italy. What we cannot do is we can't fit in Australia, because Australia is 6 times bigger than Africa. Or Dr. Google said to me, 535% bigger. So let me just, that's the size, the zones. We've got 6 time zones, of which mostly 4 of them are in, most countries are in 4 time zones. And although South Africa spans 2 time zones, we have got 1 time zone in South Africa. And I'm sure for other countries that this might be the same. I'm sure that all other countries also use 1 time zone. Let's spoke about the languages that's used. So we there's 5 business languages. So if you can speak Arabic, French, Spanish, Portuguese, English, and another language which I don't know what they do speak here, you will be able to do business in Africa, like Liz just mentioned. Because she mentioned all the languages in the DRC, but if you have to speak all the different languages or in Africa, then first go to language school to be able to do this. Thank you becomes easily or easier. Merci, Afrikaans, which I am, dankie, Nkosi in Xhosa, Asante Sani in Kenya, that becomes easier. So now I'm going to share with you centers in Africa. And first I want to mention the ARI, or Africa Health Research Institute, and Synexus, because if it wasn't for their partnership, if it wasn't for the partnership of Sipopelo and Rogamadiswe, which I'm now from now on going to call Rego and Spe, this day would not have been possible. I'm going to talk a bit later about ARI because a couple of their team members and staff are presenting. So let me just tell you more about Synexus, which is, you might know it, the company, because it's an international company working in 11 countries, been operating for more than 20 years, 75 research centers in the US, and they do their clinical trials with GCP-trained investigators. In fact, they've got their own clinical trial centers, and in South Africa, there are 3 dedicated clinical research centers. The head office is in Helderberg, which is Somerset West area, close to Cape Town, and Rego is on the call, so if you have got more questions about the Nexus, please ask her. The next company is OnQ, which I am delighted to present to you because it's not necessarily, and it is about the clinical trial management and executive services that they do and data management. But Catherine Lund trained as a clinical, a neonatal research, a neonatal nurse. Then she became a clinical research nurse with a private company called Quintals. She went on to pursue a career in contracting, and in 2006, she established OnQ. And when I joined UCT, the pulmonology department, she was already busy helping us with some of our studies to do clinical trial management and data management. She served on the South African Clinical Research Association and passionate about entrepreneurship and innovation. Her partner, Dr. Sello, brings the lab side to the organization. The next company is the MRC, the South African Medical Council, established in 1969. And of course, the mandate is to improve health in South Africa through research, development, and technology transfer. The scope predominantly is TB, HIV/AIDS, cardiovascular diseases, NCDs, gender and health, and alcohol and other drug abuse. They've got various units in the MRC working on these different diseases, and they do employ clinical research nurses, but they also work, or they also have got a collaborative agreement with what they call university chairs, so that the university and also do the research, and there's a collaboration between the university and the MRC. Another organization is the Desmond Tutu Health Foundation, which is a non-profit organization that works in collaboration with the Desmond Tutu HIV Center, which was started by Professor Robin Hood at the Faculty of Health Sciences at UCT. And the aim is to bridge rigorous academic research with community development programs. And we will see later on in the program, we will see actually one of the sites that they have got in Cape Town. Their vision is to lessen the impact of HIV and to do that through excellent research, treatment, and prevention of HIV specific, but also related infectious diseases, and predominantly, I would say, TB, because there's such a comorbidity between the two diseases. You might have heard of CAPRISA, the Center for the AIDS Program of Research in South Africa, because of the two formidable leaders that is part of CAPRISA, and the husband and wife, actually, Professor Salim Karim, who was just recently in May appointed to the WHO Scientific or Science Council, and his wife, Professor Clarissa Karim, who was also in May appointed as co-chair at the United Nations, specifically focusing on Sustainable Development Goals. Caprisa is in a province called KwaZulu-Natal. It's established in 2001, and it's a designated UNAIDS collaborative center, and their focus is also on HIV prevention. Globally, so they undertake global and local relevant responsive research. Their focus is on HIV, pathogenesis, vaccines, treatment, microbicides, prevention and epidemiology, and mother-to-child transmission. They work with partners at the universities of KwaZulu-Natal, Cape Town, Western Cape, and Columbia University in New York, and then a government organization called the National Institute for Communicable Diseases. So I had a reason why I mentioned all of these organizations to you, because I want to show you the collaboration that just happened the last 3 months between the national government, the MRC, Desmond Tutu, Caprisa, and then of course the pharmaceutical company. So they were part of a clinical trial called Sazonke. Sazonke meaning together. And it was about a pragmatic, real-world clinical trial, single-dose vaccine, Johnson & Johnson, and it was specifically for healthcare workers in South Africa. So the reason why this all started is because the government said, let's use a research program because to make the vaccine available. Because at that point in February, the South African Health Products Regulatory Authority was still busy with the licensing process to get the vaccine, that we could use the vaccine officially in South Africa. So it was a way to make research, use research to make the vaccine available, and specifically to healthcare workers, because that's a priority group that needs to be protected in this age or in this time. So we already knew that the vaccine was safe and ethical and if effective. So the government just felt that it would be unethical to withhold the vaccine until the approval, SAPRA approved the vaccine. So here's the process that the people, the healthcare workers needed to go through. In fact, the prerequisite is what we're all going to go through. You have to register with the National Health Department electronic vaccine data system. They had to register there and then became eligible to enter the study or the Sazonke program. There was an invitation to do that. Consent was given and taken. Then you got a voucher, which we will all get. For us, now that we are also eligible to be vaccinated, you get a voucher. And this was for all healthcare workers. The public service healthcare workers was serviced by the public hospitals, and the private hospitals, healthcare workers in private hospitals went through their local private hospital or a GP organization. So you confirm that you are included, and then you get vaccinated and you monitor your own symptoms. So how it worked, there was the government secured $500,000 doses of vaccines, Johnson & Johnson. The first batch arrived in February. Later doses also arrived. 17 hospitals were allocated. And this was a program driven by researchers who worked 10 hours a day, 7 days a week, because they had a window of 3 months to vaccinate 500,000 healthcare workers. So they were the researchers were responsible to ensure that the cold chain and all the consent, etc., etc. And here is pictures of healthcare workers at Groote Schuur Hospital in Cape Town, one of the tertiary hospitals in Cape Town, waiting to be vaccinated. You can see that the vaccination center, if I can call it that, was set up here in the parking garage. And here's the queue going all along. There's the people waiting. And on Saturday, this past Saturday, was the last day that of the Zonke trial. And Professor Linda Kalbacker, who was she's based at UCT, she's based at the Desmond Tutu Center, and she was one of the driving leaders in this Zonke project. She said, it's a tiring day, so this is the 14th Friday. It's the day is tiring, but most centers have exhausted their vaccines. So tomorrow, which is Saturday the 15th, is the last day, and then the Zonke trial hands over to the national government to carry on with the vaccination. Caprisa was one of the centers, and they also started to celebrate on the 14th to say thank you so much to the team. 3 months is done. Your dedication, your commitment, and your perseverance. And remember, last week was also International Nurses Day. So Professor Linda Kalbacker said, nurses rock. Where would we have been without you? So that is Cape Town. Now I'm taking you to Nigeria, where I want to introduce you to Dr. Abasi. I'm not going to try to pronounce his surname, although I've been following him for the last 4 years when he started his company called 54 Gene. The 54 stands for the 54 countries in Africa. Because of his background in genetics, his company is initially started to offer a genetic service to people in Nigeria, but also its aim is to have that genetic service in the rest of Africa. And it is about to avoid genetic samples to be sent to mostly to the US to be tested there. The results come back, and then only can the clinical staff continue with treatment or whatever, depending on the condition. So he started his company as a service, but in February 2020, he also launched a research site to the company, African Center for Translational Genomics. And the aim is to do, of course, translational genomics research. And that's why I mention it here, so that, you know, the samples can only get to them if there's somebody consenting people, somebody taking the sample, somebody seeing that the sample is transported in the right way to where it's need to get to his lab or to whichever lab sends it to him. So I thought it's important for us from a perspective of, if I can put my IACRN hat on, to say there's work that we need to do to upskill clinical research nurses or clinical research nurses in terms of research, in terms of, genetic research specifically has got that extra component. You need to know about genetic diseases, there's many questions. I've been involved. My first clinical research nurse post was in research involved with human genetics at UCT, and it was a study on bipolar disorder. And although there was a protocol, it was a Novartis-driven study. There was a lengthy interview that we needed to do with the people that we recruited. But inevitably, because it's a genetic study, people want to know about how genetics work. So there's an added component when it comes to genetic research as well. So that is what's the companies that I wanted to share with you at the moment. Of course, we will share more companies and research organizations later. But so let's first take some questions, which I'm sure it looks like I see there's 9 comments. So let me see if there are any questions. I'm going to stop sharing my screen so that we can see each other. Are there any questions? Let me just go and then do you want to think? Yes.
I have one, Elise. Thank you so much again for that. So how clever to use the research as a way to get the vaccination program rolled out. Has that been done before with other vaccines that you know of?
Not that I know of. No, not that I know of. And remember the vaccine studies, well, I don't have to tell you that, you know that takes years. So the normal, if I can call it normal or usual trajectory is all those different steps, phases that the vaccine development goes through.
Yes.
But it's never been done. Once the vaccine is given, it's because it was approved in South Africa. And I'm sure most countries use that.
And I wonder then if other treatments have been, if this has been done before to get access to other treatments, if not vaccines. Do you know?
What I know about a treatment, and now I can put my TB hat on because that's my most recent experience. In drug-resistant TB, when bedaquiline became available, it was a trial. It was done by Professor IACRN at TASC, which is a private. Well, he's also involved with University of Stellenbosch, but TASC is situated at Brooklyn Chest Hospital. They do lots of drug trial studies. So while it was busy, and before it was approved to be used in rollout in the country, there was what they called compassionate use. So doctors had to fill in pages and pages and pages of documentation to get approval that their patient could use bedaquiline, for instance. And that also happened with delaminate. So they call it compassionate use before it's rolled out in the country, across the country, across the TB program. Yeah. And I hope that answers your question.
It does. Thank you. I'm going to unmute Jenny so she can ask her question if she'd like. Jenny, if you unmute yourself now. There you go.
Thank you. Hi, Elise. Thank you so much for that presentation. I just wanted to find out, because you talked about training more research nurses. And from the experience, look, I've been in research for a couple of years, and one of the things that I try to push forward is training nurses during their undergraduate studies, because some of them come out in the third year, and even during their placement, they don't know anything about clinical research. So have you thought about working with the universities to build up that curriculum in the undergraduate program?
The short answer is no. No. But that is absolutely what needs to happen. And this question has been, or this issue, this concern has been raised during other visits with other hosts in this week that we've had this event. From South African point of view, and it has been said during the other presentations in other countries as well, unfortunately, I'm going to use the word unfortunately, the training, the schools of nursing, they do not even know what a clinical research nurse is. Never mind what should be the curriculum. That's the one issue. The other issue is the curriculum of the undergraduate, and that's what I've constantly been told. The curriculum is so full already. To add another component, and this we know because we're clinical research nurses, this is going to be a huge component. To add that component is going to either having to not offer some of the other aspects of the curriculum or to lengthen the course. But this has to become a curriculum. And I know Gordon, I don't see
He's gone. He's gone.
Yeah, but Jen can talk to what's happening in the UK. So just before I go there, Jen, where are you based, Jenny?
Well, I'm based in Medway in Kent.
Okay, great.
Yeah, I'm based in Medway in Kent, and I was just thinking, as the IACRN, is it something that we can put a voice together? Because when we look all around, we have noticed that that is a problem. And I know you say it will lengthen the course, but it is very relevant, especially the pandemic has shown us the importance of research. I always tell people the research of yesterday is the medicine of today, and that's how important it is. So even if we have to start it in bite sizes in the undergraduate, just like an introduction, and then ensure that we have placement during the 3-year program, at least they'll come out research ready. So I think as an organization like the IACRN, that's something that we can have one voice to push forward internationally.
Wonderful. Jenny, you are the poster girl for us, and yes. I appreciate that. I couldn't agree more. So I'm very fortunate to be president this year and last year, what a year, of IACRN. And I'm based in the UK as well. I'm in Hampshire, and I work as a matron in Southampton. I'm also Associate Director for Nursing for NIHR. And there's a lot of work going on to create some, even some self-directed learning tools that tutors could use with their undergraduate students to raise awareness of research. And certainly there are now placements available across the UK. So we have them in Southampton. We have 10 to 20 students at a time coming through our R&D department now. And it's a wonderful, wonderful way of sharing our work and supporting the future workforce. So it is happening, and you're right, it needs to happen. And IACRN as well will be looking, I think this will be something that we want to try to do and have done in the past, but perhaps it just needs some refreshing and relaunching some tools for students as well. We certainly have students who can join the organization, and yeah, it's definitely something I think you're right that we need to refocus on. So that's a good idea, Jenny. Thank you.
Thank you, Jen. Thank you.
You should join our organization if you haven't already. It'd be wonderful to have you and your ideas.
I will definitely join.
Excellent.
Thank you.
Thank
So just in terms of your accent, you might be in the UK, but it sounds like you are from Nigeria or somewhere in Africa, or is my ear not well tuned in?
Originally from Cameroon.
Exactly. Yes, exactly. So Jenny, why I'm also asking you is because there's just from Liz's presentation, there's a huge need in Africa for us, and Jennifer, I'm not sure that this is something that IACRN can take on. We do need to get a program, an official training program, even if that's post-basic. We can't go to each university and say, offer this as a post-basic degree or what, or diploma. There's got to be an organization that covers Africa, because there's just not enough clinical research nurses to warrant each organization to do that. And that is maybe something that the IACRN, I'm not sure what I'm involved, but I'm not sure whether that's in the remit of the organization, or whether we can expand to that.
I think, Elise, as the lead of the chapter for Africa and as global member at large on the board, I think this is something that is very much within our gift to look at. Now, as you know, based on the board certification, which you'll be discussing later, there is a core curriculum that has been written and will be published any minute now. And that's an e-publication, and that will be a resource. And I've not seen the final draft of that to see what that looks like and how that could be used. But that certainly would form the basis of a curriculum, which could stand outside of higher education institutions, but be an augment to nurses who want to take the path of research. So I think there are ways of adapting and working with the structures that exist in our international various settings. And I'm talking about America as well, because we're all international. It just depends on where you're standing and where you're looking. So it will be different what is needed in certain states across America, as well as in the UK, as well as Africa, across Europe and China and the rest of the world, and Australia and New Zealand, where there were discussions this past week as well. So I think there's definitely ways, and we need to determine what the best mechanism is to move things forward. So the first step was to develop the scope and standards, which we did in 2016. Then it's the certification, and then it's the core curriculum to get people up to the standard where they can be certified if they so wish to. So it's a work in progress.
Excellent. Our work is getting more and more and cut out for ourselves. So
but we need people like Jenny and the people on this call and people who are working in Africa to help you and us to make that happen, because it's not going to happen. Somebody said this on a call the other day in Taiwan, I think, oh, it'd be great if we had this. And I was like, well, you're going to have to make this happen because you are the people who are working there.
Yeah, I'm really ready to do that, because I'm also, as part of my role, I'm also like a GCP facilitator and consent and other training for research. So when Elise talked about a training program for research, I just thought, yeah, it's something that I really love to do. So I'll connect with you, Elise, and see what we can do in that field.
Excellent. So that's why I've added my email address for anybody who wants to. I will get to you just now, Liz. So for anybody who wants to make contact, please, my email address. Use my email address. I've added to the chat box. Liz, you've got a question.
Yeah, so I just had an added comment. I think it's fantastic, actually, Jenny, your motivation to do that. I think it's really good. I just wanted to point out everyone, because maybe not everyone is aware of that the Global Health Network, which received funding from the UK and from the Bill and Melinda Gates Foundation, actually has created competencies and quite a lot of really good training programs for countries in low and middle income countries, especially for Africa, and some of them available in Spanish and some of them also available in French, if you have this specific needs in the country. And I think, you know, from that idea, what I was thinking is perhaps we need to look at how we can foster partnerships to already use available networks that are being well connected and people are already using quite a bit who have got funding, and maybe see whether we can maybe tag along that to support the nursing and the research nursing element of it. Because it's hugely important. And the question is, often I find is that nurses are working very, very hard, but are still very isolated, and trying to reach them to them is quite difficult. I mean, we're very lucky in some other countries that we've got this really beautiful network. So, you know, using existing network might help us to just spread the word as well, if we partner.
Great idea. I think there's a lot of mapping of work and information that we need to do, and to see what already exists and where and how we can best utilize things. Yeah.
And the place to start is to stop talking about it and start doing something about it. So and I'm talking to myself.
Exactly. I've just unmuted Grace as well, who's got some experience as we have going into universities.
Yeah, so the way the program is done in Sheffield, they have hub placements, and then they have spoke placements, and we are pre-COVID, we were a spoke placement. So we would have nurses coming to us for like a week to 3 weeks, and we would arrange various visits for them to see, send them out like with our research physios if they're available, send them over to our sister sites at the Cancer Hospital, just so they can get an idea of what research is being done. And then we also had, pre-COVID again as well, we had a yearly talk that we were given to the biomedical science students on how ethics in practice actually works. And that was it was an interactive session. We filmed videos of various scenarios that they might come across when they actually went into research themselves. And that's been very well received. I don't know if anyone has ever attended the IACRN conference. We presented there in 2018 on that. And
I remember it, Grace. I remember that.
Okay.
I didn't realize it was you and your team, but I certainly remember the students. Yeah, the talks about the students that year. Yeah, so wonderful.
It's been really well received, so it's good.
And I think when it's real like that, with research nurses going in to speak to the students, it takes away some of the scary unknown bits, and it makes it much more accessible and encouraging, I think, to see that you don't have to be some fancy academic. You could be, but you don't have to be in order to do the research nursing piece. And we started with the hub and spoke model, but now we have full placements, which is a big job, but we have a large education team within our department who manage that, and even some master's students who come through as well. So there are lots of really great ways of integrating students into research departments and buddying up. It's a great model.
So on that note, I do think we can talk about this for many, many hours still. But so I'm going to thank you so much, everyone, for your contributions. I do take this on that that I will take this further and see how we can start training and getting a formal program to clinical research nurses. We're going to take a break. for 5 minutes just to stretch our legs, to stretch our brains in a different way. So I'll see you back in 5 minutes.
It's really good, Elise. Really good.
Use daily for whiter teeth in just 1 week.
Do you know that click song?
So welcome back. Let me just get to my space where we're now going to be before I start to share my screen. Welcome back. I hope you enjoyed the music. There's a little bit of a reason why I chose that song specifically, and you will soon find out why I chose that song specifically. So let me share my screen and ask Kathy to, oops, I'm going to stop sharing now and share the screen. There you go. So now what we're going to have is an interview with Kathy, who is from Tanzania. And Kathy, thank you for joining us. Kathy is from Tanzania. You can see it borders Kenya and it borders Uganda, Zambia, Malawi, Mozambique. And we're going to talk about the scope and practice of her. I call her a lead clinical research nurse. And here's the interview.
Okay.
Hello, Catherine. I am grateful that you are here today, that we can talk about you and your clinical research position and work in Tanzania. So let's just start off by tell me and tell the people that's listening to us who you are. Tell me a bit more about yourself.
Okay. Thank you, Elise. Greetings from Tanzania, and thank you for this opportunity. Shortly, I'm Catherine Gitige, a Tanzanian working in Kibongoto Infectious Diseases Hospital here in Tanzania. Mainly, we treat patients with tuberculosis and other diseases, but the core function of the hospital is excellence for treatment of MDR-TB in the country. I'm a nurse with the Masters of Science in Applied Epidemiology. I worked with the hospital for about over 10 years. I work as an ordinary nurse for about 6 years, taking care of patients. That means bedside. Thereafter, I went for my bachelor nursing. I took my bachelor nursing at KSMC, Kilimanjaro Christian Medical University. Thereafter, I worked for 1 year. After my bachelor science, I went for Masters of Applied Epidemiology. After my Masters of Epidemiology, then I came back to my work. That is when I joined the research unit. I've experience in outbreak investigation. I write my first manuscript and I have submitted, but it's not published to now, but I've given a reviewer's comment, whereby I responded to them and resubmitted. Yeah, I think this is brief about me.
That's fantastic, people. Thank you so much. We might just get to know you a bit more as we carry on with this interview. So you start off as a basic nurse, and then you did your master's, and then you got into research.
Yes.
And specifically, you involved with research for infectious diseases.
Yeah, in our hospital, we have research unit. our main research is clinical trials on TB.
Specifically TB, no other diseases. Your sole focus is TB.
Yes, the focus is TB, though there are other research which is out of tuberculosis, but the core is TB trials.
Yeah. So
Yeah.
tell me, sorry, you were going to say?
No, you just continue.
Yeah, tell me a bit more about the clinical trials. How do you do that? Who's doing that? What is your role? Who tells you, how does the hospital decide to do a clinical trial? How does it work?
All right. Here in my work setting, there is a doctor who is associate professor by now. She is PI. She applied for different funds, and then during the implementation of the protocol, automatically you need a lot of team.
Yeah.
That's where I came to join the team. I was just appointed as a lead nurse in clinical research, but also data, to observe the data during the project implementation and other essential documents of the trial. This has happened after my master's. Before, it was not my position.
So congratulations. It sounds like you are advancing in the last 10 years. You advanced your career.
Yes, thank you.
And now you are a lead. Do they call you a lead clinical research nurse?
Actually, in calling a lead, they don't call, but they give me to lead my fellows. Maybe we don't know the meaning of lead.
Yes, yes,
Yeah.
yes. But it also sounds like your role is now to look after a team and to be responsible, accountable for the data.
Yeah, I'm not accountable, but I look after those data entries to check the quality of data.
Okay, got it. So you do quality control of the data.
Yes.
And where is it entered? Is it the data entered into a online platform or on paper? Where is the data entered?
Both on paper and online.
Okay. And you need to check both, whether the online and the paper entries are correct.
Yes, yes.
So let me go back to team. How many other nurses are working with you on a research project?
Currently, we are 6 in the unit. The one has Masters of Science in Nursing Education, and the rest they have diploma in nursing, general nursing.
Okay. Is that a requirement of employment that you have to have a master's degree or a diploma?
No, in our country, you can be employed if you have just certificate of nursing. The levels, now I'm trying to explain the levels. The lower level in our career is certificate in nursing. Then they come those with diploma, then they come those with Bachelor of Science, then they come those with masters and the PhD and the professors. So the employment requirement is at any level.
Even for research, so any level of qualification can be employed to be involved in the research.
Oh, right. Basically, we are not employed in the research. We are employed by the government, but then the research unit was established as a core function of the hospital. So we are kind of mixed, those with masters, with degree, who are working together.
I got it. Got it.
Yeah, yeah.
Yeah. In my country, I'm used to research is separate. It's not a hospital employment. But in in Tanzania, you're employed by the hospital, and you allocated to be involved with the research.
Perfect. Yes.
Yes. Now you said you do clinical trials. Are there any other kind of studies that you also do, or not?
Yeah, we have another research. For instance, now we are planning to start research on addressing the non-adherence in tuberculosis. It is an epidemiological study. It is not a clinical trial.
Yes.
Yeah.
And will you also be involved in that?
Yes, of course.
You mean the nurses are involved in all the different studies?
They're involved, yes.
Yes. Now, except for nurses, clinical research nurses, which other team members do you have that's involved with the research? You mentioned the PI.
Yes, we have doctors with their qualification start from medical doctors with 1 degree, with the 2nd degree, with 3rd, and the PhD and above. Of course, we have scientists from laboratories. We have a pharmacist. Yes.
What a data manager? Do you have a data manager?
Yeah, yeah, we have data manager. Currently, he went for master's studies in statistics.
And that's why you got involved with data as well, because would the data manager actually do the quality control and everything around data?
Yeah, I'm involved. I think I have advantage because during my master's, the component of data is very important as an epidemiologist.
Yes, yes.
Yeah.
And biostatistician, have you got a biostatistician on your team?
Yeah, I think currently we don't have. He is just went for his study on statistics this last year, not this year, last year.
Great. So when you do the clinical trials, I know you're the lead clinical research nurse. So how does it work? Who recruits the patient?
The one who recruit the patient in some trials, the nurses did it. When the doctor screen the patient and they meet all inclusion criteria, the nurse can consent the patient.
And then what? And then who randomizes the patient? Or are the clinical trials not randomized trials?
They are randomized. Who did the randomization is the statistician.
Okay, and that I suppose is double blind. Nobody knows in which arm.
They are sometimes double blind. They are sometimes open label.
Yeah.
Yeah.
So the patients that's recruited, are they only hospital-based patients, or is it also patients in the community?
Initially, they start in the hospital, then after they recovered, we are discharging them for home visit, and they, of course, they given an appointment to visit the hospital. So we have both. in the community and in the hospital.
And when they're in the community, then, because you're based in a hospital, so who looks after or keeps contact with the patient when they're in the community?
All right, we have a patient identification log where we took the details of the patient. Then when they went back home, if there is a need for them to come to hospital for any follow-up, we call them. The nurses call them because of the contact we took during the admission. Yeah, that's how we operate, but also we have a community engagement. There are other people working in the community. They advocate for the patient to attend the appointments, those who are involved in the research.
So it sounds like there's a network of professionals, either people solely involved in research, but also then the community health professionals. So as a team, you see to it that the patient keeps on going on the research study, but also gets the necessary treatment that the patient needs to get.
Yeah, of course, yes.
Yeah.
Because
yeah.
there are other treatments they get out of the study drugs.
Yeah.
Yeah.
Wow, that is. So are you the only hospital in Tanzania that does clinical trials, or are there other research units in Tanzania as well?
There are others. For instance, here we are, there is nearby us is another institution that is doing clinical research. And of course, there is some in the country. We collaborate with them.
Yeah. And I'm guessing, but the fact that you did your master's in epidemiology, that is a plus. Do you think that is a benefit for the work that you're doing?
Perfectly, I think yes. Because before I went for my master's, I've just having my interest in research, but I was not sure how do I go about. Then during my master's, it has helped me to understand more. And then when I come back, automatically they see me as a potential. That's why they took me to the team.
Yeah. That is great. What you're saying, there's an understanding that you built, that you acquired for research that you did not have before you did your master's. Now, as a nurse, I need to ask you, what made you think, or what made you choose a master's in epidemiology versus a master's in nursing?
Yeah, I think we don't have so many masters in nursing here in Tanzania. I thought to have masters in epidemiology, it may give me a broad scope of thinking a research as a big topic than just narrowing my thinking to a nursing issue.
I got it.
Yeah.
So you're saying that you choose that because you wanted to your pathway where you let me ask you rather, where do you see yourself in 5 years' time?
What? May you repeat?
Where do you, if you should see yourself now in 2030 or 2025, where do you see yourself? How's your career going to be then? What's the progression of your career?
Currently, I'm looking for scholarship. If the fund is available, I may wish to have more study. That means I wish to have a PhD. But my PhD, it depends in my setting. Sometimes you may not think of other diseases if you treat a particular disease in the hospital. You may think the same direction, and the mission and the vision of the hospital is directed.
Yeah.
So I'm not sure when I can get this fund, but my career and my wish is to have a PhD so I can work more, because currently I feel like I'm just involved in the research, but I can't do much.
It sounds to me you want to become the PI.
Perfect. I think we talked this last time.
Yeah.
Yeah.
Yeah. Well, that would be perfect as a nurse, because we do need leaders that can that can cultivate the beauty and the necessity of research. So we do need that. It is a pity that, from my perspective, it is a pity that you had to do a master's in epidemiology, and that route is going to get you to being a PI, because I do know there are nurses who are also PIs. But I think in Africa, we've got not so many of those.
Mm-hmm. Yeah.
So you want to say?
Yeah, I want to say I have also learned during the years I practiced before I went for my master's. The one I said she's a professor, we actually employed at the same time. We get into an employment in the same year. Then she went for master's. Then she went for PhD. She's doing big job now. She really inspired me. I think the nurses, we need some more changes in our thinking. Everything is possible if person has passion inside of what he or she want to do. And we like not sure of why research is there. If the research findings will not be taken into practice, the nurses will continue to practice without validated knowledge.
Yeah. Well, I'm going to say this is a perfect ending for our discussion, because there's nothing more to say than to say nurses need to come to the table and excel and follow your passion and be the leaders. I think that is what you're saying.
Perfect. That's what I'm saying.
Yeah. And just imagine you are already on your way there, because you started on a basic level and you are now the lead clinical research nurse, and your vision is going to take you to be a PI. Yeah. So on that note, I really want to thank you for this interview and giving us a scope of your world, what you do, what it takes, as well as where you see yourself and where you actually see nurses in the future. I wish you well. I wish you well on your journey.
Thank you very much. Thank you very much.
So
I think I will reach where I am dreaming to, because the nurses need to change.
yes.
Yeah.
Yes. Yeah.
Yeah.
So thank you. We'll talk again.
Thank you.
Thank you for Kathy for having that interview with me. Are there any questions for Kathy? If not, then we can go to the next video clip that I'm going to show you.
You too.
So the next clip is about clinical research the board certification that Jennifer spoke about earlier, as well as a bit about IACRN. And this was a presentation that Jen did on the inaugural Clinical Research Nursing Day on the 29th of April, yes, at the Royal College of Nursing.
Hi, I'm Jennifer Allison. I'm an Associate Director of Nursing and Midwifery at NIHR in the new Nursing and Midwifery Office. I'm a matron at the NIHR Southampton Clinical Research Facility. I'm a theme lead for the UK CRF network, but I'm here today to speak to you as president of IACRN, the International Association of Clinical Research Nurses, about their new Clinical Research Nurse Board certification. I'm really delighted to be here, even though we're not really here together. It's wonderful to be speaking to an audience of clinical research nurses. And I know this is going to have been a really successful day, and I'm so excited and honored to be asked to speak today. So thank you to the organization for that, for the organizers. So today I'm going to give you a little bit of background about IACRN and about the organization that we've set up and the certification process that we've created and what those requirements are, and think a little bit about what the future might be around this, which is, I think, a very exciting one. So IACRN grew out of the General Clinical Research Center Nurse Managers Association. So the GCRCs were funded by NIH, American research funding, Department of Health government funding, huge endeavor across all the states of America. There were these research centers, and they started in about the 1960s. But about 15 years ago or so, the funding streams changed. And what had been a really vibrant nurse managers group was forced to rethink how they would proceed because their funding had disappeared. They were no longer going to be available. It was no longer going to be available for them to travel and to meet and collaborate together. So they decided then that they'd create their own organization, and they wanted it to be open not just to nurse managers, but actually to all clinical research nurses everywhere, and not just in America, but internationally. So IACRN was created, and it now is funded by membership dues, conference fees, sponsorship, and donations. And we have a clear vision and mission, which is really quite simple when you think about it. It's about maintaining research quality, enhancing that, and the safety of participants through a specialized nursing practice. Our mission has been to create a specialty practice of clinical research nursing and to develop opportunities to educate and ensure the professional development of clinical research nurses around the world, and thereby ensuring the safety of our patients and participants. The structure of the organization is a standard one with the president. I hold that office until the end of this year, then I'll be on the board next year as a past president for continuity. as well as having a president-elect who will be looking ahead. And that trio works really well this past year. It's been really exciting to collaborate a bit closely with the two women in those posts. Secretary, treasurer, member at large, and a global member at large, really important. So that ensures that there's somebody international on the board at all times. And that post at the moment is held by somebody in South Africa. It had been held by somebody from the UK before. So there are lots of opportunities for people to be involved. The committees are like the secret engine of the entire organization, really active, really important, keeps us moving forward, as do our chapters. So chapters can be across a country, like Japan, or the UK and Ireland, across 2 countries. It can be regional, like Ohio Valley. It can be a state, such as Florida, or a city like Houston or um, New York City. So it really, anything that the leadership thinks will work probably will, and it will meet the needs of the local clinical research nursing community. That's the important thing. So we're very excited. The UK and Ireland chapter, Gordon Hill and Claire Whitehouse are the co-chairs of that at the moment. And I know they'd be very interested in hearing from you if you're interested in joining them. It's a great group. We have strategic initiatives all about moving the organization forward, advancing the structures, and ensuring that specialty practice for research nurses is disseminated through the scopes and standards, and now through certification. And we really look after the professional development of nurses consistent with our mission and vision. And we're very excited about the opportunities we offer to our membership. So we're young and we're small, but we're very mighty. And we now are across 19 countries. Bulk of the membership is in America, but it's now spread across the world. Really delighted to see the most recent members from the Maldives, and I think Jamaica was a new flag I had to put on as well. We have a conference every year in October over 3 days, which is really fabulous. And we were able to pivot really quickly last year. Despite everything that was happening, we were able to hold our virtual conference in October and had 250 delegates. And we were really proud of that achievement. And they came from everywhere. And we will always have a virtual component to our conference now, I think. So the path to specialty practice has been a long one, and it's been the hard work of a core group of individuals really who created the scope standards of practice. I've almost completed the publication of the core curriculum. We had wanted that to happen prior to certification, but it's happening now in tandem, really. We're waiting for the ebook and the system of payment to be set up, and that should be within the next couple of months. So it will be on the website and easy to download. So that's a very exciting, important piece of our puzzle. But we didn't want to delay certification, and we had the 1st of April in mind, and we were able to that. So we were really delighted with that sort of soft launch, and we're looking forwards to October when we expect many more submissions. So scope and standards is really important because that describes in detail the difference between us as clinical research nurses and our general colleagues. It also clarifies this for our colleagues, which is important, our multidisciplinary team colleagues, and for the public and our lovely patients, of course. And it provides a foundation for certification. And it is a resource that can be used internationally and is being used internationally, which is very exciting to see. So the core curriculum, along with the scope and standards, will provide this foundation. Just going to see if I can move that a little bit, and establish this specialty practice certification. So it's about the knowledge, the skills, the expertise, and the clinical judgment that's required. This credential, CRN BC, very exciting, can't wait to have those initials after my name in October, I hope, is the only nursing certification that recognizes the expertise of clinical research nurses. And it's earned through professional portfolio. We took that decision, and I think it was the right one. And we worked really hard to make it internationally obtainable. And it validates our performance as experts in clinical research nursing. And we followed the guidelines of the Accreditation Board of Specialty Nursing Certification, which is the only such body that certifies clinical research, any nursing program. And we wanted ours to be part of that as well. So it is about advancing our knowledge and skills, and it's a continuing process to maintain. So this isn't for new graduates. This isn't for people who are brand new to research nursing. This is about showing our commitment to the work of clinical research nurses and demonstrating our expertise and judgment. And it's a value-added achievement. So it exceeds the minimal requirements. So it's more than just a research, nursing license or registration, as we would call it here in the UK. It's more than just the scope and standards, which are the minimum standards. So that was something that we had to work really hard to develop. So it's a 4-step process. So it's about practice hours and license or registration. It's about continuing education records, and it's about professional development activities along with a written exemplar and a CV, of course. So you need to document your license and your practice hours. So this isn't very difficult for us to do, is it? So we have an unencumbered nursing license or registration to practice. You have to be practicing for at least 2 years prior to application for certification, and you need to have 4,000 hours as a clinical research nurse within the previous 3 years. So again, it's not for someone who's new to the role. So for continuing education, the focus has to be within the last 3 years as well. There's a number of points that are given for every activity, and you need to have a minimum of 36 points within the last 3 years. To document professional development within the last 5 years, there's a number of ways to do that. And I was really keen that this was something that would really be specific to the role of the clinical research nurse and sorts of things that we do as clinical research nurses. So this isn't just an academic achievement. This is about our professional development. And between the step 2, the continuing education, and step 3, the documentation of professional development, the points earned would be 100. Some of the things that you could get points for would be presenting posters, podium speaking at presentations, such as this one, writing SOPs, editing, writing articles, working perhaps as a committee member for IACRN or on the board, being a preceptor or a mentor to nurses or to novel investigators, as well as academic education. So it is something that clinical research nurses who aren't going down a clinical academic route would also be able to obtain. Then there's a written exemplar, which relates to our own personal growth and development and our practice and the way we work within our team and collaborations, as well as specific quality and safety. And there's a rubric that helps to explain this on the website as well. So the importance of recertification. So it was decided by the team creating certification that they wanted to show what would happen at the end of 5 years. So you achieve your certification in October, it's good for 5 years. Then what do you have to do? So they've created 2 options, and along with practice hours, again, within the 5 years, it's 4,000 practice hours, which is equivalent to like half-time working as a minimum. And the point system is similar to the certification that was done in the first instance. And again, all of this is clearly explained through some guidance documents on the website. There are 2 windows each year. They're going to be open 2 weeks prior to the deadline. So mid-April and mid-September, submissions will be accepted. And the fees are reasonable compared to other certifications that are available. So it comes, when I calculate it in pounds, to being equal to about £50 per year for members to achieve this. So how does this work in the UK? How does it work anywhere outside America? These are discussions to have, but it's here and people want it. I think it demonstrates that we value our nurses. I think that we have amazing new recognition for clinical research practitioners within our teams, but I know nurses are asking, what about us? I wanted to get this recognition too. There's nothing that I have that I can sign up to that shows I have this research expertise. And I think this certification fits that really well. And I am in discussions with the Director of Workforce at the Clinical Research Network about this, and thinking about how we take it forward. But it is here, and people will be going ahead. And I guess it's for us as leaders to think about how do we support this and how do we encourage people to think about how their contribution is recognized. So I'd like to thank the leaders of the CRNBC. So Shauna, Meg, Tam, and MJ have been amazing. They were the same people that wrote the scope and standards with input from colleagues around the world. So hugely dedicated group. Lots of information is available online, including a handbook and submission instructions, the rubric, application checklist. So do go to IACRN.org and have a look around at the organization. And I hope you're going to consider joining us because it's a fabulous organization. And we are always open to have colleagues joining us from wherever they are. Follow us on Twitter, IACRN, the UK and Ireland branch has their own Twitter feed as well. And they're very active with that. So look forward to discussing this further with you all. And I hope you enjoy the rest of your conference. And thank you for listening. And do take care.
So that is the background that that I wanted to share with you. And instead of Jen doing this again, I thought, let me just share what she's done before. So we're now going to go into a panel discussion. And the question that we're going to ask is, who is a research nurse? What is required regarding the scope and practice of research nurses in Africa, including the need for certification? On the panel is Kathy, which we just heard the interview with, is Liz. We heard that opened our morning for us or with us. Liz is going to be here, and Emmanuel, or as I got to know him, Zamu. So I'm going to ask you to unmute yourself. Liz, can you unmute yourself? Zamu, can you unmute yourself, or do I need to unmute you? There you go. And maybe Emmanuel, if you can you just, there you go, so that people can see you. I think let me start off by asking Emmanuel to introduce himself, because you are the one person that we don't know who you are. The others we've got to know a bit this morning. Not allowed to be muted. Okay. So can you just please share with us who you are?
Thank you, Elise. Thank you, Elise. My name is Emmanuel Zamua Keshungwane. They usually call me Zamo. I'm from Durban, but I currently work in Eastern Cape, but I'm in South Africa. I obtained my diploma in nursing at the Literature College. Then I did my BCare honors at NMU in critical care. I did my education with them as well, and nursing education, and then nursing management at Stellenbosch. I also did my master's with NMU, and currently I'm in a process of doing my PhD, so I'm busy with my proposal. I'm currently working at the public college in Eastern Cape as a nurse educator. I've been practicing since 2010 now. So it's approximately about 10 years now that I've been working as a nurse. Yeah. Yes.
And my question to you, thank you for that. My question to you is, what made you say yes to me to be part of being on this panel?
I think, firstly, I didn't know about the concept clinical research nurse, but I was aware of the research nursing. So when I heard about it, I said that it's a very good concept and I want to be part of it. And I think what made me to decide that I want to be part of a panel is because I thought I'll be able to contribute and also understand. And I think it will also give me a platform to easily start a conversation with the students, so that when they leave, even if the concept is not out there approved by our accrediting body, but the conversation itself will easily begin with the student while they are doing their undergrad. Hence, I decided, let me be part of the panel and then see where it goes.
Excellent, excellent. So very grateful for you to be here with us, and we will talk more. Just wanted you to introduce yourself. Liz, shall we start with you?
Sure.
Who is a clinical research nurse?
A clinical research nurse. A clinical research nurse, I think, in my eyes, is anyone who, as a nurse, is really, first of all, believing in evidence-based practice and advancing science. And alongside that, by default, especially depending on which profession, which type of nurse you are, so whether you work with pediatric or not. For example, so I'm a pediatric nurse by background. So by default, all pediatric nurses are research nurses because, 60% of the drugs we use have never been tested in that population. And we're giving drugs to patients every day. So I really believe that, research nurses, clinical nurses are by default research nurses anyway. But the clinical research nurse is really, for me, in terms of pragmatic terms, is the nurse that is really a nurse practitioner and is at the same time supporting the development of further research and further evidence-based practice. And I would keep it at that big scope, because in what I have seen many nurses who may not have the role of clinical research nurse, but actually are already doing the job in many ways. So this is what the clinical research nurse for me is. And I'm glad we're having this topic today in this conversation, so that maybe we can make it more adjustable to the context of where we work.
Yes, I think that is an important point that you're raising there, or that you're putting there. Kathy, can I ask you, Who is a clinical research nurse?
Thank you, Elise, for your question. Do you hear me?
Yes.
Yeah, thank you. I think a clinical research nurse is a nurse who conducts clinical research, and a nurse who can conceptualize and come up with she can conceptualize and come up with the plan and how to conduct the research. Is the one who is just not undertaking the research, just adhering to the protocol, but she has a bit thinking on research and the other good clinical practice. The nurse who can identify the gaps in the research, in the nursing practice, either clinical or any other nursing practice, she can identify the gap and come up with the idea and focus on how to solve that gap. I think that is my thinking. Thank you.
I'm just for everyone to know, I'm muting myself because the neighbor is mowing the lawn. So you might have a bit of background noise at the moment.
We don't hear it. I don't hear it.
Okay,
No.
great. That's
I've got
good to
someone
know.
coming with a Hoover later, and that's going to maybe make a noise too.
Glad
It's
to hear
Mike.
that because I'm so aware of the noise in the background. So, Emmanuel or Zalmo, who is a clinical research nurse?
I think coming from the background where I say I wasn't familiar with the concept per se, but in my thinking, I would say it's someone who has done at least a basic degree or a diploma, which qualifies the person to practice as a registered nurse, of which, in my understanding, that person has a basic knowledge of what research is and what it's all about, and I think has the ability to apply the research processes and understand those different protocols in terms of your consent when we're dealing with participants. And also, I think that person should be competent enough also to understand the field where we're dealing about the diseases or conditions. So in that field, I will say generally a nurse, a registered nurse or a nurse who has undergone the training and has a basic knowledge of research. I think that would be for me a research nurse. And the reason why I think I'm saying that is because in South Africa, for instance, some of the nurses are actually participating or are doing clinical research, even though they are not aware that they are doing it. And even though those who are doing it, they haven't not received any special training, but they are actually participating. So I think in that is how I define it.
So can I just ask you, what do you mean they participating in research, but they're not knowing that they're doing that? Just give us a bit of more context on that.
I was talking to someone about the work that she was doing. She was saying she was part of the group that was involved in testing. I think it's the clinical trials. She's testing medicine. So I was saying to her, so are you now, since I know the term, are you a clinical research nurse? She was saying, no, I'm just part of the team. So then I realized, but this person is a clinical research nurse, even though she's not a lead nurse, but she is part, because when we were talking about her scope, she's saying, I make sure that the participants are aware of what is going to happen, which means the information that is needed by participant is given correctly and on time, and they are not forced, but they are a willing participant, which means then she is part of the team. She is doing it, but she does that, the term that I was using, that she was not familiar with the term clinical research nurse.
Now, I would like, Liz, I would like your response to this, and from your perspective.
Yes, I would agree with that. I would completely agree with that. I think also the reality is that many nurses are actually acting in what you would call in the UK or in I think sort of Europe, a nurse practitioner, because they are doing a lot of prescribing. They are doing, you know, usually nurses are not so and more kind of more general with a lot of specialities as well alongside that. So, you know, the nurses would be doing multifaceted jobs, and the ones that have received further education usually end up working in research by default. So I would completely agree. I think they're just not aware of that, which is why I refer to the beginning that I think any nurses kind of supporting evidence-based practice is a research nurse and should be called a clinical research nurse. And I would say until the term is more generalized, because everyone is already working at a different level. I mean, my perception when I decided to train as a nurse in the UK, I came from my role modeling had been nursing in Africa. And actually, when I arrived in the UK, I realized actually the nurse in Africa is the doctor in Europe. You know, it's the junior doctor, because they do everything, you know. And so I think in terms of what's available and the fact that we also have not so many doctors and the nurses have to take on so much more, actually maybe we need to think about recognizing that clinical research nurses are actually, you know, already there. They just don't know, like you said, Emmanuel, they don't know the terms, and they don't know that that's what they are, and they don't know maybe that there's this support network around them to facilitate that, so they can, you know, have that strength and that voice to talk about GCP and evidence-based practice. Just get the tools, but they're already there. They just don't know it. So integrating that as part of the main curriculum, I think, is essential to move forward, so that they realize that actually there's support, and that is actually a branch of nursing that, you know, they may not even be aware of.
Yeah, thank you for that. I've got my specific reaction to what Zamo just said, but let me ask Kathy, what is your take on what Zamo said, that nurses are involved with research, but they do not know that they are clinical research nurses? What's your response to that?
Yeah, thank you. I think basic foundation during the study, it might impact the definition of who is clinical research. In our country, we go through different curriculum, and the research is taught as research in general. But then when you go back to the work setting, sometimes you may not find the research activities going on. So you have just learned in theory, and there's no way you can implement. But then when it comes to the implementation, the nurses were taken in the research as a team, but sometimes fail to identify that they are researchers. And I went through I was looking for the nurses who are working in my country in the national level, the National Institute of Research, who are looking for their publication, but I didn't see it. So this I don't know how I can define.
We can't hear you. Something happened. We heard that something happened. We can't hear you. Can't hear you.
Maybe go and come back, Kathy.
I think she might have put a setting. Kathy, can you just... No, sorry, we can't hear you. Maybe just log on it again and see if
Hello. Hi.
There you
That's
go.
better.
You hear me?
Yes.
Yeah. May I repeat what I've said?
You can just carry on.
Okay. I said I was trying to see in the country record of the nurses.
Now, something is happening when you talk. Jennifer, Jen, please take over. The noise is getting a lot here. Please just.
Okay. So I'm so sorry I had to step out of the presentations. So you're talking about what clinical research nurses are. Did you play the
We did.
presentation?
Yes.
Okay. And have you had any discussion around that yet?
Not yet. Can you hear the noise in the background?
Very minor.
Yeah.
It's not disruptive. I think you should carry on because you're doing such a good job.
So the question we're actually busy with now is what is the scope and practice? Because Emmanuel or Zamo said that there are nurses who who are involved in clinical research, but they do not know that they are clinical research nurses. So I've just asked Liz and Kathy, their response on that. And Liz said she can understand that. From what I get from what Kathy's saying, she says she can understand it. From my perspective is, and I would like to hear Rejo and Sipopelo and any other clinical research nurse who's participating, even if you just put it in the comments, I cannot understand that people will not know that they're clinical research nurses because in our setting, you are employed as a clinical research nurse, which is separate from a post at the hospital. And that's why I can't understand it. So what Zamo also touched on was training. He's involved he's an educator, he's involved with the college, and he's now saying that he will talk to his students about clinical research nursing and nurses, because up to now, he didn't really know that such category existed. If I'm paraphrasing you correctly, Zalma. So maybe in terms of time, we have got till 12 o'clock for this session. Can you tell us who is a clinical research nurse? What do you think the scope and practice should be? And what about certification in Africa?
Who are you asking?
You.
Okay. Nothing like being put on the spot. I could easily just say I agree with Emmanuel. But I think also this idea of people doing bits of research and not realizing that they're engaged in that activity, I think that could be an unfortunate thing. But some of the data collection is standard of care work. So there are studies certainly that we're running in the UK, and perhaps you are as well, where there are procedures, treatments that are being done by clinical colleagues. So the research nurses would come in with the protocol and set up everything that needs to happen, but the actual treatment comes from the hospital pharmacy and is delivered by the clinical nurses caring for the patient. So we would normally make sure that there was some training, that they had an awareness of the importance of the timing of the treatment, the collection of any blood samples or other samples that needed to happen, or other data that had to happen in relation to the giving of that treatment, things to look out for. So we wouldn't consider those nurses necessarily as research nurses, because they are just really doing what they would normally be doing for a patient. But they're really a huge important part of getting the studies delivered in that way, because the research nurses aren't always able to be there 24/7 to look after the patients and the treatments that are needed. I think there's been this sort of saying for a few years that every nurse should be a research nurse, or every nurse is a research nurse. And I think, yes, I would say that would be brilliant, that everyone has that same sort of knowledge, the same opportunities to do this amazing role that we have. But I also think that there will always be a place for that extra expertise that someone like Kathy and others on the call have, that ability to see the big picture of the protocol and pull everything together and work alongside the multidisciplinary teams to get the data that we need to maintain the patient safety, to understand the bigger picture, the ramification. Because if I didn't believe that, I wouldn't be president of an organization that represents research nurses, because I think in and of itself, it is a specialty practice. It is an amazing field to be in. The presentations today had me all over the place emotionally, because it is such an amazing thing that we do for people, and times when the only treatment we can give people are the research studies that we're presenting to them. So it's a huge privilege, but it's a lot of work, and it's a lot of expertise and a lot of learning and training to get to the point where you can safely say, I'm the research nurse, I've got it sorted, I need these other people, I'll support them, I'll train them, I'll help them to be part of it. But actually, this is where I sit in this field, and I'm the expert and I am the specialist. And I think that that absolutely is an important thing to not lose sight of when we say, oh, everyone should be involved. Absolutely. The more the merrier. But that doesn't mean everyone's a research nurse. They're taking part in the research and doing their important role. We can't do it without them, but we are the nurses and we are the research experts. That's what I think.
So please talk about the certification. I'm just going to close my door and see if I can get rid of some of the noise.
So certification, this is why the organization was created. The organization was created to get recognition for the specialty of research nursing, and it did that. It created the scope and standards. The American Nursing Association, who doesn't do this lightly, agreed, and it took years to get to that point, that we are a specialty practice in nursing. Brilliant. And then the next step was to get certification. So the requirements, and this was driven by our American colleagues, because in America, in order to progress, research nurses who qualify as nurses do their training, they register or get licensed. In America, it's a license. You have a license to practice. I still have my license in New York State. Each state is awarding your license following an exam. So you go through your training, then it's a 2-day statewide exam that you sit, and then you can get your license to practice. So that was the process I did, and I was able to deactivate it when I left the country. But should I go back, I have the ability with training and whatever they require to reactivate my license. So that allows you to work. And then if you apparently now, and this is different from when I left almost 30 years ago, apparently now, in order to practice, you need to advance, in most academic institutions, you would need to have a specialism, and you'd need to be board certified in a specialty. So I was working in pediatrics when I left. I was working in intensive care, pediatric and neonatal intensive care. So I would have probably gone on to be board certified in pediatrics or peds intensive care or neonatal or those sorts of things. So that would mean that I could then move up the ranks and advance in my clinical practice. This isn't an academic practice necessarily. So it might mean that I would also go and do a higher degree, but this is more about the clinical work. So there was a huge desire for research nurses affiliated with IACRN to get clinical research nursing declared a specialty practice so that they could be board certified in clinical research nursing. And I might have chosen to do my pediatric boards certification, but then I would go and do the research boards as well, board certification. So it's something that there was a huge appetite in America for. So in the UK, I get a bit of pushback sometimes. It's like, so what? Why do we need it? Why do we need to pay to have this? What difference will it make? And I think it's a way of what I'm going to do, and I'm in discussions. We have a new director of nursing now for all of the research infrastructure in the UK, which is amazing. She just started this week, and she's a wonderful person, and she is very open and interested in this opportunity for nurses. I also have a director in part of the infrastructure who's in charge of workforce, and that's most of the nursing workforce, actually, that gets funded through hospitals to run research. So between these two directors, they're at a point where they're receptive to hearing about it. And one of the things they see it as is a way of valuing the research nurses, recognizing their experience and expertise, and a way of perhaps retaining research nurses and nurses. So if you were in a position as an institution to say to your research nurses, let's pretend you're running a hospital, we think you're amazing, and for £50 a year for each of you, we're going to support you to become board certified in your specialty. And that means that it will take you, if you're a new research nurse, it will take you about 3 years to be able to apply for that. And during those 3 years, you'll stay with me in my institution. If I'm running my hospital, maybe you'll stay for 3 years. Yay, because that's a problem for us, recruitment, retention of nurses in research or in anything in across the UK. So if we're able to say £50 a year, we put it away, hold that money for you, and you'll be able to then apply. We'll support you to go for getting this recognition. Because alongside of this, at the moment in the UK, is a registration for people who aren't nurses in research. So they're called clinical research practitioners. So these are people who might have a science degree, but not a nursing qualification, no nursing training, no nursing registration, but they'll be working within a team of nurses supporting them. And this came to be, mostly it was London to begin with because of the nursing shortage, where they thought, we just need people to help with the data. We need people to help. We'll train them to take blood because people are phlebotomists. They don't have to be a nurse to take blood. And they started to develop skills around the nursing team to support the delivery of the research. So some institutions have them as junior to the nursing staff. That's my institution. We took the decision that we didn't want them to be equal or senior to the nurses. We thought nursing has that qualification, and that these without the qualifications should sit below. Some institutions, they have them at the same level, and they even have higher and quite senior people. There's some who are as senior as me, and I'm senior. And that's very interesting to me. It's not the path I would go in my institution, but because there's this process now that clinical research practitioners can be registered on a register to say that they meet the standards of research delivery, and they get to have this recognition. The nurses are saying, what about us? Can we be on that register? There's nothing that recognizes my research experience and expertise in this country. What about us? I think board certification through IACRN is the answer for them. So the CRPs get their register. Very nice. That's good. They're going to develop standards. There'll be some education programs. That means it's safer because people will be working to the same levels. They all have GCP and things like that, but they don't have the necessary standardized research training. And some places are doing more than others to support them. The nurses will be able to go and get their board certification. So they feel that they have as well, rightfully so, the recognition in their field of expertise. So that's how I think it might fit here. I think in other countries and other places, it's going to take discussions like this. It's going to take thinking about how does it fit? Does it fit? I think just as we have, and they're going to kill me for this, and maybe I shouldn't say it, but I'm going to say it. Just as we have a sliding scale for membership to IACRN from other countries around the world, where the salaries are not as high as the American salaries, I think we need to consider a sliding scale for certification as well. Now, I'm not in charge of the certification because it sits outside of IACRN, which sounds odd, but you can't certify yourself. So we have to have a separate group, a council who's doing that. But they could be influenced by me and Elise and other board members to say the feedback we're getting. So hearing feedback from you, that would be helpful because we could then go and say, actually, the feedback we're getting is people want this, there's an appetite, but we need to consider, just as we do with membership, just as we do with conference fees, a sliding scale to attainment for nurses such as you who have experience and the desire to get some recognition. So I think it's about local discussions and decision making. And it might be that it's country by country. So to say we can speak for all of Africa, you know, just like, you know, we can't speak for all of Europe through the UK anymore. I think it's really about looking at what is practical and fits. But I wouldn't want people to be excluded because of their location. And that's something I've always felt very, very strongly about, inclusion. It's better to have everybody there and learning from each other.
Absolutely. So I'm fortunate that the grass has been cut. There's now going to be silence on my side. Liz, I see you sit on the tip of your chair. Well, that's how it looks like from here in South Africa. What do you want to say? And I'm also looking at time because we are supposed to end at 12 o'clock, my time, 12 o'clock. Let me put it at the top of the hour. So a minute from you. What's your input? What's your take?
So I really welcome your words, Jen. I think they're very wise, and I think I welcome everyone's contribution. I think in many ways, certain countries in Africa, like Tanzania, where we already do phase 1 clinical research facilities, there's really good setup. You can actually talk about CTU setup, or South Africa was the same, has got this, in a way, a little bit of that privilege that is a lot more, as well as Kenya, a lot more set ready to facilitate that. But certainly the sliding scale will be welcome. And I actually think that I would be willing to put myself forward, because my key thing why I joined this and I'm really motivated is that I've not done the normal parkour either. I've done a very sort of taken many ways along the way. I'm very committed, or very proud of being a nurse, and I think very much I'd be willing to support capacity building, and I think maybe we also need to think maybe about a scholarship where maybe people can have an exchange between, even in Africa, so that we can have some people from certain African countries that can go and visit others. It'd be great maybe if we can have an exchange between even French speaking and English speaking.
This is what I wanted to do, and then there was a pandemic. I was so cross. I was so cross. And this is what we would normally have done, because we had wonderful people lined up to visit the UK last year at this time of year in 2020. And we had to cancel it, of course. But yes, lots of sharing. Sorry to interrupt you, but I just...
No, this is it. So, I'm all for that. I'm all for the sliding scale for participation. And I think the more we share, the more we will be able to sort of, enhance confidence as well in people. I mean, I'm going to point the finger at Isaac, who's on the call. I love Isaac. He's a great role model. He's working in Lesotho, and actually he's a nurse practitioner. He's a typical, clinical research nurse at a very high level. And, and it's just having that network and being able to speak out and being given the platform so that, other people that actually from the countries can... I'm a facilitator, but I'd like to have people who are working on the ground coming next time and sharing that and coming with ideas and providing a platform where we can have more different country representation as well.
Yes. So I've just put something in the chat. I want to hear, I would love to hear from everybody. If you go to the website of IACRN, the certification is on the front page. And it would be really good to get your feedback. And if you could share that with others and feedback, perhaps your group, your colleagues that you work with, their thoughts around what that certification, because it's a portfolio. When I was talking about the boards, I don't want to get confused. The state boards where you qualify as a nurse, that's different from the board certification, which is by portfolio. And that was something I pushed for because I wanted it to be something that people could build from their own experience. I also wanted it to recognize the research work, the clinical research bits and pieces that you do. It wasn't just about a degree. It can be, because you can use that towards your portfolio if you have the higher degrees, but it could be about presenting here today. It could be about attending other conferences. It could be about writing SOPs for your colleagues. All those very research, nursing, hands-on tasks. So lots of ways of building up that portfolio, but it would be really great to get, Elise, if I put my email, maybe that was a mistake. Maybe it should be your email to pull things together in some way so that we can start to build consensus that we can then take to those who've created the certification with thoughts around cost and accessibility and anything that you all come up with. Be great.
That is a good point, Jen, that we actually speak to the people who created the certification. What I'm undertaking is, because we are now a bit over time, what I'm undertaking is to organize a day or a morning or a session that we dedicate to just speaking about certification, because I'm sure everyone, I would like to hear from Rick, Spare, Rick, everyone on the call, so that we discuss this as a community of practice, if I can call it that, and take that to the certification, the people who initiated the certification. I am going to stop, and I really, Jane, I just see your comment. Maybe this also applies to you in New Zealand. Not maybe, I'm sure that this also applies to you in New Zealand. So I'm going to stop us this session. Thank you so much to Liz, Zamo, Kathy, and Jen for a very fruitful discussion. and taking it from here to the future. It wasn't just a discussion about a nice to know idea, but let's take this to the future. We're going to have a 15-minute break.
Is that our lunch break? Is that all you're giving us for lunch? Is 15 minutes?
Do you want? As I said when we started, we on Africa time. So if you need some more time,
I wouldn't dictate to you, Madam Chair.
Let's be back. Let's say it's now 10 past the hour. So let's be back. Shall we be back at past? We're way outside our time frame then, but let's have a 20-minute break and not a 15-minute break. Let's make it easy. Be back at past, whatever the time is in your country, past. Thank you so much. Enjoy your break. I'm going to add some music for you to do some exercise while you are taking a break. Liz, I know you might not join us when we come back. Thank you so much for the morning.
Liz,
and
you're amazing, Liz. Yes, thank you so much. It was so beautiful. And I'll talk to you soon, I hope.
Yes, and you too, Liz. Thank you so much.
Fige kasi zola sungaboni dombe ya segoli. Asanga ni kanang bamalana ngegalana. Then my friends told me I'm slow. I'm shying on high and I'm shying smile. I'm doing now oh yeah baba now take my hand. Wazang it tokalinda baba mbolami na isala pants and I'm singing like I sing full no tando lwak. Kizi yo ya koya dalelo mina. Angazu yang fabu yang keep. I may be crazy, don't mind me, but hey, I'll just straight it up. I'm being a Santa, so on Dele Tuesday. Come on now, follow my lead. Come on now, follow my lead. Yes, it's time, this is all sako. Don't think that I know you. Kiss you, I'm in Calico, Yoga. Yes, it's fair, I'm on Zimbabwe. It's all so good, I'm easy. What all is that you got, yes. What is she and if we get money? Yes, it's fair, I'm on and I'm singing like I sing full new tando lwak. Kizi yo ya koya dalelo mina. Angazu yang fabu yang keep. I may be crazy, don't mind me, but hey, I'll just straight it up. I'm being a son. Come on now, follow my lead. Come on, be my baby. 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 Wanna give me my baby, 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 my baby, Jalon J. Come on, be my
to. Money, I'ma front you. Girl, I wanna flaunt you. Right. I'ma always want you when nobody wants you. If I die now, my love will still haunt you. Mace ain't the one that'll pay for your phone. Mace be the one that'll take you home. That's even right. Though I'm not the one that gave you the stones on your days alone, I can make you moan. Everybody know I got more bounce than an ounce. Bad boy, get more money than you can count. Why I'm buying things you can't even pronounce. I do it to you, cat, for a large amount. And when the beef come, you know where to be found. Why I be around till the winner is announced? Here you go, girl, with thousands in your palm. Why you can't let bygones be bygones?
Where do I go? What must I do if I can't live without love? Thinking of you amaze me, feel, baby, like I'm the only one for you. Girl, I want, oh yeah, I need you in my life, oh baby. Why can't we make it happen? Oh baby, oh baby, I
thought I told you that we won't stop. I thought I told you that we won't stop. I thought I told you that we won't stop. I thought I told you that we won't stop. I thought I told you that we won't stop. I thought I told you that we won't stop. I thought I told you that we won't stop. I thought I told you that we won't stop.
and I need you.
Nothing like ice cream on a cold day.
Joy and pain. I like sunshine and rain. Ooh. Love can be bitter. Love can be sweet. Sometimes devotion and sometimes deceit. The ones that you care for give you so much pain. Oh, but it's all right. They're both one and the Don't it seem we go through life going up and down? Seems the things that turn you on turn you around. Always hurting each other. If it ain't one thing, it's another. When the world is down on you, love somewhere around. And I want you to know that joy, like sunshine, ooh, joy,
Hello everyone, so we're back. I hope you had a good movement. You had something to eat. We're back to, I'm just reading the comments, can't leave now enjoying the music. Jane, the music of Africa is, one cannot leave if that is what is in your blood. So what we're going to do now, we're going to have I'm going to share my screen. We're now going to have a couple of team members from ARI, the Africa Health Research Institute, who's based in KwaZulu-Natal. And I thought, let me just tell you something about the organization, purely from what I got from the internet. But the team members are on the call and they could answer any questions that you might have. So it's an independent transdisciplinary research institute with 2 campuses in KwaZulu-Natal. And of course, the vision is to provide optimal health and well-being for the under-resourced population. To understand this, they do research, population research, basic research, social research, and medical sciences research. And they partner with local communities as well as academia, government, and other stakeholders. But let me introduce you to the first group. It's Guguletu Shazi, Sipepelo Dlamini Spe, I hope I pronounced it correctly, and Fikile Mdaba. And they're going to tell you about the journey, their journey as clinical research nurses in rural KwaZulu-Natal.
Okay, greetings to you all from KwaZulu-Natal, South Africa. My name is Ntsiga Sithole, and I'm a research nurse working for the Africa Health Research Institute. I am joined by 3 of my fellow colleagues who will be introduced to you in a moment, and they will take you through their journeys as the clinical research nurses so that you can hear about their experience of research nursing from our part of the world. So first up in our list is Miss Kuku Shazi. So Kuku, can you introduce yourself and tell us when your journey as a research nurse began?
Good day, everyone. As mentioned by Ntsiga, my name is Guguletu Shazi. I am a clinical research nurse based at ARI, which was previously named Africa Center. I joined ARI in September 2015.
Oh, okay. So what was the study that you joined in 2015, and what were your duties during that study?
So in 2015, when I joined ARI, I was based or placed in a project called EQUIP, which is an acronym for a longer word, which stands for Essential and Quality Implemented in Primary Healthcare. So it involved the implementation of a pilot study whereby it decreased the workload of clinic staff at the clinics by means of issuing treatment for 3 months rather than 1 monthly course of treatment. So it also, the outcome would then be of fast pickup and, as mentioned before, decrease the workload that the staff are having at the local clinics. I then moved on to, from 2016 to 2017, I was involved in a project called PIB, which is a population intervention program, which is also based at ARI. And the project involves HIV testing of patients or people in the community. and thereby being linked to the local healthcare facility. So I would be based at the clinic and facilitate the linkage of care of patients to the Department of Health. So I would ensure linkage of care, initiation of participants into ART, and also work closely with the Department of Health. From 2017 to 2019, I was involved in a lot of activities within ARI, whereby I was a lead nurse in adverse events reporting system, which involved the reporting and review of any clinical incidences which are at the field where staff are based. And my sole responsibility was to be able to monitor these incidents in co-facilitating in good clinical practice training, whereby staff which come into RE for whilst conducting an induction and orientation, they would thus be involved in any training with good clinical practice, which is GCP, whereby I also inform the staff on reporting of clinical incidences happening within the field. I was also involved in infection control, whereby I was the lead nurse in monitoring or conducting any trainings regarding any infection control within the institution in ARI, and being able to monitor any progress and any trainings that have occurred. I then was also involved in being a deputy nursing manager role, whereby there is support of staff members allocated within the team at the fixed clinics. So any logistical things which they might need, I would be responsible for, and scheduling or ensuring that all meetings are in place and all the communications are in place for them, for the team members based in the local healthcare clinics. I would also be involved in any liaising with the Department of Health or the stakeholder, and ensure that the relationship is maintained accordingly, and introduction of any RE projects which are taking place in the local primary healthcare clinics.
Wow, Kuku, you have filled many positions within the organization, which is great to see. Can you tell us your current position and tell us what this position, what duties this position entails?
Okay, so I saw an opportunity for a research study coordinator within the institution, as in ARI. So my current position is a research study coordinator for a project called DISCO. So DISCO is an acronym for a longer word or a longer title for the project, which is Population Effectiveness of Dolutegravir Implementation in Sub-Sahara, a prospective cohort study. So basically what the study involves is to monitor the experiences of patients which have been switched from a first-line TE regimen to the first-line dolutegravir-based regimen. It's looking into the experiences of patients, of participants. It is hoping to recruit 1,000 participants, and one site is based at Uganda. So my core responsibilities are to monitor the staff or supervise the staff, and to coordinate any DISCO project activities, also implement the protocol and organize any meetings which might need to be in place in the project, thus ensuring that the outcome of the project is met.
Thank you, Kuku. It is truly amazing to see how much you've grown professionally within the many different roles that you played within the organization. Thank you so much once again for sharing your journey with us. Next up on our list is Mr. Sipepelo Dlamini. Spe, kindly introduce yourself and tell us about your journey as a clinic research nurse.
Hi, Nzika, and good day, colleagues. I am Sipepelo Dlamini. I am working at Africa Health Research Institute with my other colleagues. I have been a research nurse from October 2013. So it's been about 8 years now that I've been involved as a research nurse. It's been quite an interesting journey. For an example, when I started, I was working as a professional research nurse in a clinical cohort that enrolled HIV positive participants that were starting ART. So we would initiate ART following the guidelines and then follow those participants up through their journey with ART. Now, it involved both the clinical management of participants. So I was still a nurse in a clinic, and I was also involved in research. So I was administering consent, explaining about the study to them, and then obtain consent, and then enroll them onto the study, and then follow them up. Also complete the case report forms, the CRFs. It was quite interesting, especially because I was working in a number of clinics. I had 5 clinics under my care. So I would visit different clinics each day where I would enroll or engage the study participants. I did that for about 2 years, and then there was an opportunity for me to actually act as an acting head of the clinical research department because the head left. So I then acted for a year as the head of the clinical research department. At the same time, as I also started to be a backup nurse in occupational health services within our organization. So I was assisting the occupational health nurse during that period. So that was quite interesting as well, just being involved in all these different roles.
Yeah, I see you've occupied many different roles within the organization, which is great to see in terms of exposure. So with regards with career development, how far have you come with your academic journey? Are there any courses which you are currently involved with?
Yes, I am. It's very interesting because I've just submitted my proposal for the master's project. And recently I completed my honors degree. And every year I give myself a target of at least 5 certificates to make sure that I can obtain 5 certificates of short courses. So I've already in 2021, I already have the first one. So I'm working towards the other 4 now. But the main project or the main career development that I'm involved in now is my master's project, which will start soon. We are just finalizing the proposal with my supervisor, and then I'll start it.
This is great to hear, Spey, and good luck with your master's. So in terms of your current position, first and foremost, and what does this position, what are this position's duties? What does it currently entail?
So currently I'm a clinical research nursing manager at Africa Health Research Institute. This position, I've been in this position since 2015. Now it involves a broad range of activities. For an example, the key function of this position is that I am a principal liaising officer for the organization with the Department of Health. So I engage the Department of Health at various levels. I engage them at sub-district level, which includes the clinics and the hospitals where we work. So I engage the operational managers and the nursing manager, the different coordinators that work for the Department of Health. I also then engage the Department of Health at a district level or at a regional level, and then also at a provincial level. So I engage them on a regular basis. I've got meetings with them. We visit healthcare facilities together. And this position as well, the clinical research nursing manager position, also includes a lot of planning, oversight management, I've got administrative tasks. I also look at the finances of the department, and I make sure that the different clinical research projects and the department are actually compliant with the regulators or the regulatory requirements. And I also engage funders and collaborators from other organizations in my position, in this position. I also have an important role where I line manage nurses within the organization, both from a human resources perspective and from a material resources perspective. So I also conduct performance reviews with them. I manage their contract renewals and contract terminations. I also work with the regulators or the regulatory authorities in South Africa, your ethics committees, and I also work with the Department of Health research committees to obtain approvals from them. And I'm also involved in ensuring that the different projects within the clinical research department actually comply with the requirements, also with the good clinical practice or GCP as it's known. My role goes as far as ensuring that all the research projects within the clinical research department at ARI are actually running smoothly, and we actually meet all the obligations that we have from both a principal investigator's perspective and from the funder or collaborator's perspective.
Wow, Spe, it seems like you have a lot on your plate. Are there any professional memberships which you belong to?
Yes, I have maintained a number of professional memberships because I believe that they are important for my career development. So I am a member of the South African Nursing Council, which is a requirement by law that if you're practicing as a nurse in South Africa, you've got to be a member of the South African Nursing Council. But we are launching right now, we are establishing a very exciting project that at the moment we are referring to as the South African Research Nurses Network, which is focused on career development of all the nurses in South Africa that are interested in nursing research. So it's still at its founding stage or at its conceptual stage, but we are getting there. So I'm excited about that as well. I'm also a member of the Southern African HIV Clinicians Society, which advises the National Department of Health in South Africa with regards to the management of HIV and TB in South Africa. Lastly, I've also maintained my membership of the Health and Other Services Personnel Trade Union in South Africa, which is HOSPESA, the acronym. And that one mainly provides me with two things. It provides me with the legal representation if and when I need it, and it would also provide me with professional indemnity if and when I need it.
Thank you for sharing your journey, Spe. It is truly inspiring to see the strides you have taken within the organization. Good luck once again on your master's journey. Next up on our list is Miss Fikile Mdamba. Hi, Fikile. Please introduce yourself and tell us about your journey as a clinic research nurse.
Hi, Ntsika. Good day, colleagues. My name is Fikile Mdamba, as Ntsika has just mentioned. I am a clinical research nurse working for the Africa Health Research Institute. My journey as a clinical research nurse started back in 2013 when I started working for a study that was called Treatment as Prevention, also known as TASP. Through this study, we wanted to reduce HIV incidence, and it was a study that was divided into two arms. There was the intervention arm, which initiated participants regardless of their CD4 count, and then the control arm, which followed the ART guidelines, National Department of Health ART guidelines back at the time. So we wanted as well to improve accessibility to the mobile points, because we had about 22 mobile points where the participants, after being tested for HIV in the field, they would then be referred to the point. Those mobile points were available all the days of the week, as in like from Monday to Friday. And for busier places or for busier points, we would be available on weekends just to cater for participants that were like working, who would be unable to reach the facility or the mobile facility during the week. So another thing what we did was to make sure that linkage to care of those participants was possible, and as well as making it a point that the point was just based on one area, one point, each point, so as to make sure that people would get used to that the point is at that particular place. So we wanted as well to see how cost effective it would be to treat a participant, initiate them on ART regardless of their CD4 versus using the ART guidelines as with regards to the CD4 count. So it is through studies like TASK that we were able to reach what is now known as the universal test and treat, of which people now, when they test, after testing, they would, regardless of their CD4 count, they would be initiated into ART. So what I was responsible for as well was to do quality control of study equipment, like your CD4 point of care matching, just to ensure that it was in a good working order, and that the results that we would get would be of high quality and very reliable. Our mobile points were very accessible in the sense that it was just a 15 to 20 minutes walk for the participant from their homesteads to the point. So that in a way boosted or it promoted the ART adherence, as well as, you know, committing to the care on the participant's perspective. So that was what we were responsible for, what I was responsible for under the TASP study. So in 2016, the study came to an end in June 2016. But before that, we were placed in different DOH facilities to receive the participants, because they would choose which healthcare facility was they preferred. So we were now linking them back to care, just to make sure that they would not interrupt their treatment, because you can imagine when a person has been used to a very reliable and very convenient way of getting their treatment, how challenging it would be going back to you know, having to queue, because, you know, there's long queues at the healthcare facilities. But then we linked them back to the PHC clinics, and it was such a smooth flow. And then they went back to their clinics, their local clinics. Then after that, there was the population intervention program, which I started in 2017. In that study, what I was responsible for was facilitating linkage to care as well of participants who would have been tested at the field by the field workers, and then making sure that they are initiated on ART. That will be part of implementing the study protocol, and as well providing appropriate primary health care to study participants, and then making it a point that they are then linked to the DOH, because we would only see them initially when we link them to care, and then afterwards pass them over to the DOH nurses to like continue with their care after, of course, initiating them and taking the relevant blood specimens and screening them for, you know, the different, like your STIs and cervical screening, and making it a point that we take the relevant bloods or specimens for the study. Then another role that I was playing was a supervisory role of the clinic research assistant, whose responsibility would be registering participants when they come to the facility, and then they would then hand them over to the clinical research nurse, which was myself at the time, and then I would like carry out all my duties that I was supposed to carry. So another responsibility that I had was with regards to linkage to care, then a lead nurse role, which was given to me to say, after a participant had been tested, I would then look at how to facilitate their linkage to care through support calls. So what would happen, the procedure was, one would be tested at the field, and then they'll be referred to the healthcare facility where there would be an Africa Health Research Institute, PRN, who would then receive them. But if it happens that a participant doesn't like go to the facility, to the healthcare facility as expected, because they would be given something like 7 to 10 days to say they should go to the healthcare facility. If they happen not to link to care during that period, at day 14, they would be then given, sent a message as a reminder to say they should link to care. Failing which, after 30 days of a positive HIV test, they would then receive a support phone call from the linkage to care nurse lead, which was myself. And then we would be looking at what challenges that the participant would be facing with regards to linkage to care, because some would maybe be complaining of the fact that they are financially not okay, like if the healthcare facility is maybe a long distance from home. Some would be like dealing with disclosure, you know, talking to their relatives, and the fact that they haven't disclosed to their relatives or their significant others. So it would be such a challenge. Then we would talk about such, and then I would be giving health education with regards to the importance of starting ART, the importance of linking to care, and the support that we will be giving them, and as well the fact that when they link to care, they would develop that relationship with the nurse, the ART nurse that they would find at the clinic, which would make it easier, like to deal with whatever challenges that they would be facing. So that was it. And then later on, I was then given a task or a role of participant protection, but mainly focusing on child protection. Our field workers, when they get to the homesteads, they would find different challenges or different concerns that they would feel there is a need to refer them to the participant protection nurse lead. Challenges like abuse, you know, there's physical abuse, there'd be history of, you know, sexual abuse and the like. And then they would then report that to me. What we have done is now there is a good relationship, stakeholder relationship with the Department of Social Development. So I would firstly, depending on a case by case, I would visit a homestead and then assess that particular participant. And then based on my findings with regards to the assessment, I would then refer them to the relevant stakeholders, like
Hello, everyone. We're just having a moment of technical difficulty, but we will get back on track. Just bear with us a moment.
Can you hear me?
Off guard. Yes, that caught me off guard. I looked up and suddenly everyone, you disappeared, Elise, and the talk had stopped. So
There was
sorry,
just
everybody.
I'm so sorry, there was a break in my internet connection, but I'm back. Shall we continue?
Absolutely. I'm going to make you host and you can make me co-host again.
Okay. So let me share my screen with you.
It's also interesting, everyone's journeys and work. So impressive what people are doing.
So let's see, can you admit that?
Yeah.
Let me admit.
And every time I admit someone, it cuts your video, it seems.
Yeah, that is
to study participants, and then making it a point that they are then linked to the DOH, because we would only see them.
I think we would
initially when we link them to care, and then afterwards pass them over to the DOH nurses to like continue with their care, after of course initiating them and taking the relevant blood specimens and screening them for, you know, the different, like your STIs and cervical screening, and making it a point that we take the relevant bloods or specimens for the study. Then another role that I was playing was a supervisory role of the clinic research assistant, whose responsibility would be registering participants when they come to the facility, and then they would then hand them over to the clinical research nurse, which was myself at the time, and then I would like carry out all my duties that I was supposed to carry. So another responsibility that I had was with regards to linkage to care, then a lead nurse role, which was given to me to say, after a participant had been tested, I would then look at how to facilitate their linkage to care through support calls. So what would happen, the procedure was, one would be tested at the field, and then they'll be referred to the healthcare facility where there would be an Africa Health Research Institute, PRN, who would then receive them. But if it happens that a participant doesn't like go to the facility, to the healthcare facility as expected, because they would be given something like 7 to 10 days to say they should go to the healthcare facility. If they happen not to link to care during that period, at day 14, they would be then given sent a message as a reminder to say they should link to care. Failing which, after 30 days of a positive HIV test, they would then receive a support phone call from the linkage to care nurse lead, which was myself. And then we would be looking at what challenges that the participant would be facing with regards to linkage to care, because some would maybe be complaining of the fact that they are financially not okay, like if the healthcare facility is maybe a long distance from home. Some would be like dealing with disclosure, you know, talking to their relatives, and the fact that they haven't disclosed to their relatives or their significant others. So it would be such a challenge. Then we would talk about such, and then I would be giving health education with regards to the importance of starting ART, the importance of linking to care, and the support that we will be giving them, and as well the fact that when they link to care, they would develop that relationship with the nurse, the ART nurse that they would find at the clinic, which would make it easier, like to deal with whatever challenges that they would be facing. So that was it. And then later on, I was then given a task or a role of participant protection, but mainly focusing on child protection. Our field workers, when they get to the homesteads, they would find different challenges or different concerns that they would feel there is a need to refer them to the participant protection nest lead. Challenges like abuse, there's physical abuse, there'd be history of, sexual abuse and the like. And then they would then report that to me. What we have done is now there is a good relationship, stakeholder relationship with the Department of Social Development. So I would firstly, depending on a case by case, I would visit a homestead and then assess that particular participant. And then based on my findings with regards to the assessment, I would then refer them to the relevant stakeholders, like your service providers. Like if it's a social issue that requires a social worker, a participant would then be referred to the social workers or the Department of Social Development. We have such a good relationship with the Department of Social Development, so it makes it easy to refer participants, because the Africa Health Research Institute is not a service provider. We are a research institute. So challenges that would require service providers would either refer them, if it's a clinical challenge or a clinical case, would then refer it to the Department of Health, or whoever, like your community care workers, who are known as the CCGs, would refer. It just depends on like, it's a case by case thing. So I would refer them to the relevant service provider. So another responsibility that I have under the participant protection lead nurse role is training employees, newly employed RE employees, with regards to participant or child protection issues, and as well as assessment of capacity. When participants get recruited into different studies, because there are different projects, and amongst those projects, like this portfolio is an RE-wide or is an institute-wide responsibility. So what I would do is I would be like liaising with different projects with regards to training needs, if there are any training needs, with regards to assessment of capacity, because when participants get recruited, we want to make sure that participants that are recruited into the relevant the different studies do not lack capacity. But if it happens that maybe a participant that lacks capacity would maybe have been recruited, we do not like apply the blame culture. It's a no blame culture, because it would be a learning opportunity. Then we in a way establish what needs the staff have with regards to training. Then we would train the staff on that regard. So the adult participants, we encourage them to like self-refer in a way that a child and an adult, they would have different needs, and an adult would easily go to a relevant service provider, unlike children, because we are in a way trying to make sure that we take care of our children, of the child participants. We like cater for whatever needs that would arise. As part of my role as well, I would sometimes be invited to outreach events, mostly under the Department of Social Development. They would invite me maybe to conduct or to do some talks on child protection or participant protection issues. And we are like working very much closely, and we have such a good relationship with them, which in a way helps the institute with regards to maintaining good stakeholder relationship.
Wow, Figile, it seems like you have a lot on your plate, Sisi. In terms of career development, are there any courses which you are currently engaged with?
Currently, I'm doing my nursing management at the University of South Africa, which in a way is like helping me to be able to my skill with regards to education, because mostly during the trainings there'd be a lot of challenges, and it helps me to be able like to be more skilled with regards to teaching and with regards to like facilitating the trainings. So it really is helping me in a way.
This is great, Sisi. All the best
Could
with
you
your
tell her
studies.
that
Are
I
there
need
any
quiet up here
are there any
at
professional
2
memberships which you
o'clock?
belong to?
I am a registered member of the South African Nursing Council, and as well the Nurses Research Network, which Mr. Dlamini talked about just now.
Okay. Thank you so much for sharing your journey as a research nurse with us, Figile. Your journey sounds really exciting, and we cannot wait to see what the future holds in store for you. Thank you so much, Sisi.
Thank you so much, Siga.
So this brings us to the end of our dialogue, folks. We hope that our session was both eye-opening and educational at the same time. Thank you for sharing your time with us. Thank you. Bye.
So thank you for sharing your journeys with us. I now lost all the comments that was in the comment box, so I don't see any chats. So Jen, I saw there was about 9 while I was still on the line. Do you have the chats in that you can just help me to see what they said?
So in this last section, so the thing about the chat, it will be saved in the recording. Every time we leave and come back, we lose the chat ourselves. You're right. So that's unfortunate. So the earlier chat, all of that will be available later. So since we restarted, I'm just checking. Okay. So everyone was enjoying the music during the break. People were very pleased to hear about the journeys people had and the career stories. Very impressive collaborations, I said, with integration into the Department of Health at such high levels. It's really amazing and wonderful for research nurses. I was encouraging everyone to join IACRN as a professional organization. Sound, people were having trouble. And then that was it. People were losing connectivity, and then we all came back. So I don't see anything from this session. Any questions?
Excellent. Thank you. Thank you for that. So at the moment, have you got any questions for the team before we move on to the next presentation? No? So let me move on to the next presentation, which is actually going to be by the person who just did the interviews, which is Nseka Sitoli. And he's going to talk about undisclosed antiretroviral therapy used at primary healthcare clinics in rural KwaZulu-Natal, a DUART trial sub-study.
My name is Nziga Sitole, and I'll be presenting undisclosed antiretroviral therapy use at primary healthcare clinics in rural KwaZulu-Natal, South Africa, a DUART trial sub-study. I was a study coordinator for the DUART trial, but I am principal investigator for this study. The study was a collaborative effort by the University of Washington, who led the DUART trial, the Africa Health Research Institute, and because I used the study as basis for my master's, the University of KwaZulu-Natal was also involved. The DUART trial recruited people living with HIV who had detectable viral loads, meaning that we were taking viral loads at every screening visit. We recruited participants from the community and primary healthcare clinics, but the study setting for this study are the two circle clinics, namely Madoleni and Kundosi clinics. We found out that a proportion of people living with HIV who tested positive at the clinics actually had undetectable viral loads. This was occurring without them revealing that they were on ARVs. We did a literature search and found out that the undetectable viral loads are most likely caused by undisclosed out-use. We then assessed the prevalence of undisclosed out-use at initiation and explored its correlates among people living with HIV initiating ART. We estimated the proportion of individuals presenting for ART initiation with undetectable viral loads. We then fitted regression models to identify social and clinical correlates for those presenting with undetectable viral loads. We also explored clinical databases to see if we could find previous ART history. Then finally, we measured tenofovir and metrosydopin levels in blood spots to confirm undisclosed ART use. From a total of 193 people who tested positive at both clinics from February to November 2018, 62, which was 32%, had undetectable viral loads. The multivariable regression model revealed that female sex, having a prior HIV test and having disclosed their HIV status, and having a partner with HIV were associated with undetectable viral loads. We were able to find previous ART history in 68% of the records we reviewed, and found tenofovir or metrosydopin in 60% of the samples that we tested. We found out that 1 in 3 individuals presenting to the clinic for ART initiation had an undetectable viral load because of undisclosed ART use. This has implications for resource planning in the region and must be known to policymakers. We were able to find previous ART history in 68% of the records we reviewed. That is why we recommend nurses working at the clinics to have access to a computer, internet, and electronic databases so that these records are easily accessible to them. Female sex, having a prior HIV test, having disclosed their HIV status, and having a partner with HIV were associated with undisclosed ART use. We therefore recommend that a viral load should be taken at baseline if faced with a patient with all of these characteristics. The reasons behind non-disclosure remained unclear, but we hypothesized that having a social network with people living with HIV promotes undisclosed ART use. We therefore recommend that future research should explore this hypothesis. For the next steps, we plan to go back to these participants to find out why they did not reveal their ART history at baseline. We are ethically covered to do so because the DUART screening consent form, which is seen on the screen, has the following sections, and all 62 of these participants indicated that we can contact them for future research. So this planned work will be part of my PhD journey. I've just started on the concept notes, and the title is Why I Chose to Hide, Patients' Perspectives Around Non-Disclosure of Antiretroviral Therapy When Initiating HIV Treatment in KwaZulu-Natal, South Africa. In terms of the acknowledgements, I'd like to thank the DUART Principal Investigator, Dr. Ryan Barnabas, for allowing me to do this study. We are also grateful to the people of Mkhayabuti who participated in the study. From RE, I would also like to thank the RE DUART team. I'd also like to thank Dr. Mark Sedner, who did the analysis with me in the study. From the University of KwaZulu-Natal, I'd like to thank Professor Mashabela, who was my master supervisor. This study was generously funded by the Bill and Melinda Gates Foundation and is under review at the journal AIDS and Behavior. Please look out for it once it gets published.
I see you shaking your head, Jen.
It's just fantastic.
You muted.
Congratulations on the paper.
Yeah.
Really amazing.
So, you know, what Nsika just presented is the front end of the study, or the I can call it the showcase of the study. So what he did with Guguletto, they did an interview, or she did an interview with him to talk to him about what I call the behind the scenes. What is actually happening behind the scenes to get to this point that you can produce these excellent academic presentation. So listen to what he's saying about what it took for him to get to be able to present this.
Okay, let's go.
Well done, Nzika, on a very impressive and a great academic presentation. There may be some interest into what the role of the clinical research nurse is in conducting such research. Thus, let us discuss the behind-the-scenes work that we have done to accomplish this thus far. We will start from the presentation that was just given. So for the benefits of fulfilling the intention of work presented at the IACRN Day, which is to give the behind the scenes story as well, let us go through what might have been of interest. So what does it take? Particularly, what is the role of the clinical research nurse to get research done in order to present the final product as you have done?
Thanks for the question, Kuku. So basically, for the final product, like the presentation that I've done, you have to go through the process of going through every step of what a principal investigator does in order to be able to conduct the research. That is writing a protocol. After writing a protocol, submit to ethics for ethical approval, waiting for ethical approval, once getting ethical approval, and then going for data collection. After getting data collection, analyze the data. After analyzing the data, you write up your manuscript. So basically, I went through the same process that all the other primary investigators go through in order for me to be able to present the end product that was just presented.
All right, so you mentioned in the presentation that you were the study coordinator for the DuArt trial, and then the PI for the sub-study. Basically, as a study coordinator, to get the job done and to ultimately get to the point you were now able to produce in the academic presentation, what did you need to do and what actions did you take?
Okay, so as you mentioned, I was the study coordinator for the DuArt trial and I was the PI for the sub-study. So everything first had to happen with the DuArt trial first because the DuArt trial led to the sub-study. So what happened is that as a study coordinator, you know, the principal investigator comes with the protocol and says, this is what I want. Now, my job is to turn that protocol into reality. So from writing the SOPs of how the data collection should be done, where the recruitment should be done, the number of vehicles the number of mobile vehicles that we should have, the number of personnel that should be there. Yeah, basically everything that needed to be done for data collection, I had to do. So yeah, basically I had to change the protocol into reality. Make it a point that what is wanted in the protocol is done in reality. Yeah, basically it was that.
Interesting.
Yeah.
So regarding background, you mentioned people were recruited from the community. The map clearly shows that the communities were a substantial distance from each other. So regarding that background, is this where the work of the CRN comes in? And what did you as a study coordinator or as a PI need to put in place in reality to recruit and interview those patients? And what did it take to get that part of the research job done?
Thanks, Kuku. But as previously mentioned, I said I planned everything in terms of recruitment. So basically, in terms of the job profile of the clinic research nurse, they worked in conjunction with clinic research assistants. So we had For clinic research nurses, 2 were stationed at the 2 primary clinics that were in the study area. The other 2 were in the mobile vans going into the communities and recruiting from the community. So basically, we had recruiters who went front into the community, tested people, because we were dealing with people. We were recruiting people who were HIV positive. So they tested the people. Once they found that they were HIV positive, they then called our mobile teams, which had clinic research nurse and clinic research assistants. They would go to the site. The clinic research assistants would test the patient. If the participant was HIV positive, then they would give them a chance to join the study. If they agreed to join the study, that's where the clinic research nurse would come. They would take the bloods, take all necessary measurements, and then initiate the patient if the person was randomized to a community arm. Yeah. And as previously mentioned, I was the one who had to plan everything prior to having all the personnel being added to the study. So yeah, I basically planned everything.
All right.
Yeah.
So briefly going into the methods that you had used as a study coordinator or as a PI, what did you need to do or need to put in place in reality regarding re-regression modules, re-exploring databases, re-getting the labs to measure the ART, or were you as a study coordinator or PI not involved in this part of the study?
Thanks, Kuku. I'll answer the last question first. I was involved in every part of the study in that regard. So the biostatistician that I worked with, I was lucky in the sense that I had somebody who was willing to teach at all times. He was based in America, but when I started the in terms of learning stats and everything, I didn't know a thing. As you know, we are not taught stats at nursing school and college. So everything, this was brand new to me. So I had to, I found somebody who took me step by step. And mind you, he was in America. So at the time when we started, he gave me 3 hours per day. So each and every time, it was 7 o'clock in the morning, it was 1 o'clock in the afternoon, this side. So each and every day from 1 to 4 o'clock, we would do stats on an everyday basis, working on this databases. We worked on its on each and every step. There was not a single table or a single number which was done without me. I was the one leading there, but he was mentoring throughout the process, which I think is a very good lesson, Kuku, in terms of nurses who want to go a bit further into the scientific field. The best lesson that I can tell them is that find a good mentor, find a person who will give you the time of day, because I won't lie to you, the end product that you're seeing now is because of the mentor that I was working with. In terms of testing the samples for ARV levels, also I was also very much involved. Luckily, the lab that that actually tested the samples was the lab which was also doing testing for the DUAT study. So basically, when I got the go-ahead from the DUAT PI, who I thanked in the acknowledgement slide, that I could test the samples for ARVs, I actually went to the lab. I had already created a rapport with the lab, and they said yes, they do test the samples, and they just gave me a figure. So I went back to the DUAT PI with the figure, and she said go ahead, sign. And then they tested the samples for me. After a couple of weeks, they gave me back the results, and after that, we analyzed the data and we wrote up about the results. Yeah, so basically, I was just involved in every single step.
Okay, so you do mention the biostatistician. Would you like to further discuss the collaboration with the biostatistician to what you have mentioned just now? Because you have an acknowledgement slide.
Yeah, as I mentioned before, he was my mentor in every single step of the way. He gave me the time of day. You know, when you're going to something you don't know nothing about, you have this fear that, hey, I'm gonna mess up, But he was not like that. He took me through each and every step, and worked with me through each and every things I never understood, up until at the end of the day I did understand. And he was also even there when writing up the paper. He was mentoring me throughout the process, and yeah, as I said before, any nurse who would want to take up this part of the journey, I would really recommend that they get a mentor who is willing to give you the time of day, like my mentor has.
All right. So regarding next steps, when talking about the next step regarding yourself, will the CRMs have a role to play in the PhD? If so, what would the role possibly look like?
Thanks, Kuku. So currently, I do not think for the PhD they will be involved per se, because um, the PhD will be purely a qualitative paper, because what we're doing, we're going back to the participants to ask the reasons why they were acting the way that they were doing. So the paper the study will be very qualitative, and depending upon the type of funding that I find, I think I'll be working with mostly social science research assistants. So currently, for the PhD, I do not think that I would have clinic research assistants, but because our study is confined to 2 clinics, my hope is still in my head. I haven't discussed it with the committee as of yet, is to expand to other clinics to see if this problem is not confined just to 2 clinics, but other areas as well. If that idea comes to light and we find the funding, then of course we will have clinic research nurses, because at the end of the day, if we find HIV positive people, they would need to be initiated.
So thank you, Tsiga, for the good work, and we are proud to know somebody like you and for contributing to research. We have come to the end of our session, of which first the final product and then the behind the scenes work has been covered. The ultimate intention being to make it clear what it takes to get research done by CRMs in particular, in order to present the final results related to the research project. So thank you very much, Ntsiba.
Thank you so much, Kuku. Thank you so much for availing yourself for interviewing me. Thank you so much. Bye.
Okay. Bye.
So there you have it. The before the scenes. I know there isn't something like before the scenes, but what you present to the public and at conferences, and actually what happens behind the scenes. I see there's a couple of comments, and Nsika, just absolutely, you can see people just applauding your work, to say, well done, amazing, congratulations. Another super research nurse doing everything and learning stats remotely. That is absolutely amazing. That is amazing. And that made me think, what if we are mentors for other nurses who's interested in research, but also nurses who wants to become clinical research nurses? Instead of waiting till they employed, what if we, the community of clinical research nurses and people involved in research, what if we become the mentors?
I think you should do that. That's another one for your list.
Yes.
Absolutely. I mean, you could even just have like drop-in sessions like this. Come and learn about research nursing, and you could play some of these talks. You don't want to scare them with too many stats at the beginning, though, but come and just hear about the role of the research nurse, the sorts of things that you do, and have an opportunity to ask questions of people who are working that way. I think that's a brilliant idea. I'm going to steal it as well. I think that's the way to do it. And with everybody using Zoom and things like this these days, it makes it much easier for people just to have a coffee morning, or a chat, no, lunchtime chat. Everybody sit around with their lunch at a certain time and people drop in if they're available to ask questions.
Yeah. So absolutely. Before you go, Spare, I just want to thank you in front of all of these, the commit or the people on the call. Thank you so much for availing yourself and your team to do these interviews and to give us a perspective on not just what ARI is doing, but what clinical research nurses are doing on the ground. Thank you so much for attending. Isak, I'm going to put you on the spot. I briefly heard this morning that Liz said you're from Lesotho. So have you got any input that you want to share with us or your thoughts? Jen, if you are not able to unmute people.
I'm sorry, who was it?
Isak Rengera. Somehow when I say
I would do it. Ask to unmute. Okay. Isaac, if you could now unmute yourself, Isaac.
I'm putting him on the spot. You don't have to.
I think
I'm just. Yeah, because you're from Lesotho, that would be great. It doesn't look.
You need to unmute now, Isaac. I've clicked, unless he's walked away from his device.
Computer, yes.
Oh, here, no. Sorry. I've clicked the request.
Okay. Not a problem. So if there's have you got any other questions or comments? Can you please put that in the chat box? And now I just need the indication. We can take a 5-minute break, or we can have the next presentations, which is short interviews as well. What shall I do? Do you want a break?
5 minutes.
Yes. Yes.
Please.
So let's take a 5-minute break and then we'll be back at 1:45.
And fugitives. Hooded eyes and weary brows seek refuge in the night. They are the scatterings of Africa, each uprooted one. They're on the road to Bella Manga, beneath the copper sun. Yip-hoo-ha, yip-hum-hoo-ha, yip-hoo-ha, yip-hum-hoo-ha,
while we wait for quarter two, welcome Laurie from America, and welcome Claire from the UK. I'm not sure where, Helda, where are you from? Can you please put that? I see you're not muted, so maybe just tell us or put that in the chat box. I said Helga, I mean Hilda. No. Okay, so let's, the next presentation is an interview that was done by, this is why I needed the click song this morning, because the interviewer is called Xolelise. And I'm sorry, that click is not part of my Afrikaans tongue. So she interviewed Nom Dubulo on the journey of HIV prevention amongst communities in KwaZulu-Natal through the eyes of a research nurse.
Greetings, everyone. This is Xolisile Ngobo. I am a professional nurse who is currently working for a research company called Health Systems Trust. It is my pleasure to have you guys with us at this moment. We are actually going to be discussing a topic today that is, we're looking at the journey or the milestones and the challenges that we as South Africans have faced ever since the beginning of HIV. So we're looking at the journey of HIV prevention through all the years that HIV has existed for about 4 decades now. And also we are looking at everything that has been done since then until now, the milestones, the challenges, but we are looking at all this through the eyes of a nurse, of a research nurse specifically. We're looking at all this also among the Black communities in South Africa, which is where we actually have worked. But before I go on too far, I'm going to allow my colleague who's here with me to actually introduce herself and tell us who she is, her career journey as well. Over to you, sister.
Thank you, Sister Xolisile. Greetings, everyone. I am Nonjabulo Bohlela, a professional nurse. Actually, I'm a clinical nurse practitioner who is based at a clinic right now under the Department of Health. But my journey, I've worked in different hospitals under Department of Health, and I've also worked in NGO doing research. So right now I'm at the Department of Health. I hope this interview will enlighten you guys to see what exactly is happening in South Africa regarding HIV prevention. Thank you.
Thank you so much, Sister Bohlela. So with that, we are just going to go straight into it. So I'm going to be your interviewer for today, and I'm interviewing Sister Bohlela here, and she's going to just take us through everything. As I'm asking her, I may add here and there, but before all that, I would like to put a disclaimer that we are not specifically today quoting any research study. We are not quoting any paper as such. We are just talking about our own experiences as professional nurses who've been working in these communities. So we are looking at all this HIV prevention through the eyes of a nurse. So that is just a small disclaimer that I wanted to throw in there. So Sister Bohlela, let's just go straight into it. We know that HIV has existed in this country for about 4 decades now. And we know that it has been a very long journey, a very challenging journey. We are coming from a place where people's lives were lost. You know, we were coming from the era of the 90s and 80s, where we saw a lot of people losing their lives to HIV in our country, South Africa, and Africa as a whole. So if you can just take us through the very first methods that were introduced to us as the public in South Africa when HIV came into place. What were the very first methods that were introduced to us as the Black public in terms of HIV prevention?
Thank you, Sister Kolisile. Firstly, I'd like to note that during those years when HIV was killing people, it was a very bad time for us in South Africa, especially as the professional workers, health workers. So there was nothing that was like specific to the HIV prevention that was put in place, except that we used the methods that we thought were the best. We thought that they could help in alleviating this problem that we were facing. So we came up with the letters ABC. A stood for abstinence, where we encourage, especially young people, not to have sex at all. You know, if you haven't started dating, you should just think there's no man, I cannot have sex now. And then B, we had a B which stands for be faithful. Like we know, going to our history as a Black man, especially, that's it was a norm for a Black man to have many girlfriends. But you know, we were trying to attack that sort of a norm that you need to have one partner, at least one partner, so that you know that if both of you are negative, it's gonna stay like that, you know. And then there was a C, which stands for condomize. The government was trying everything he could at that time. So he gave out condoms for people to use when they're having sexual relationships, you know. So those were the methods that we were using at the time.
Okay, so looking at the ABC methods, that was the first thing, that was the only thing we had at the time, that we were encouraging people to be faithful to their partners, to abstain from sex, and also to use condoms in terms of trying to prevent being infected with HIV. So tell us, what were the challenges with those methods? Did they work? Did they succeed? And did the public know about these things? Did they know they have to do these things? What were the challenges with those methods?
Hey, I don't want to lie to you, Sister Kolisile. Whatever thing that we try to introduce, it will always have challenges. There will always be, let me put it like that, there will always be challenges with whatever method we try to introduce to our communities. Because first of all, the social standings, the social norms that people live under is not the same, you know. We would give health education at the clinics, because they would come in numbers at the clinics to test, to you know, when they're sick. We will go to media, you know, we'll tell them on their TVs,
so the information
using
was
the
out
TVs,
there.
using the radios, using even in the clinics, would put information on the walls, the posters, even on the roads, you'll find posters talking about these things. But you won't believe me when I say people still did not use those things. A few people did use, but most of the people did not believe in these things, you know. Hence, we still have HIV even today, you know. But there was a Zulu culture for young girls, the virginity testing. I think that played a role as well, because all the girls that were still virgins, they would go and be checked, you know. So that was our pride. So we encouraged also that, because we could see that that is helping us.
So you mean in the KZN community specifically for the Zulu speaking people of South Africa, there is a culture whereby girls would go to a certain ceremony where they do virginity testing. So you're saying that's one of the things that helped in the prevention as well. How did that help?
Because, you know, the children, to them, it was their pride to keep their virginity, you know. So when they go there, they are checked, and then they will put a dot on their forehead
to prove that they're still virgins.
So they were really proud of that. So it made them to want to remain virgins.
So it helped with the abstinence
yes,
part
in the abstinence part of it.
But did we see HIV actually? Did we see less people getting infected with HIV? I mean, during those times and during those APC times, did we see people getting less infected with HIV?
You know, as HIV has been increasing like nobody's business. And I think one of the other things that was the cause of that is poverty. Because here in South Africa, we are poor. Most of the time, people are very poor. So it's where we find the term of the blessers and the blessees, because young children will fall in love with older men just so that they can give them money. And people go and work and do jobs that will give them money, like the sex workers. There's a proper name for that, which I've just forgotten. But they would go out there and sell their bodies because they needed money. And if I am going to pay you, if I say I don't want a condom, you won't use a condom, you know. So
basically, we're saying all these three methods really never worked.
They really never worked.
They never worked in terms of decreasing the spread of HIV, or in terms of preventing HIV from spreading and actually decreasing the incidence.
They really never worked. They really never worked.
I see. All right. So it's as you can see, it was a really challenging time for all of us, and for us as nurses as well, because we worked in these communities and we saw people that were coming into the clinics infected with HIV, and instead of people actually adhering to the methods that were being presented, there was a lot of challenges with those methods. So we needed things that were going to actually come in and work in terms of HIV prevention. We needed things that people can take, things that people can use to actually prevent HIV. So let's maybe look at research. How has research played a role in terms of HIV prevention? Do you know of any studies that maybe have been done to actually help with HIV prevention, things like that?
Yeah, there are few trials that have been conducted by research companies. I can remember of a DREAM study where they looked at the young women, I think about age 15 to 24. They used a ring, a vaginal ring, yes. But still, that didn't talk to the HIV incident, you know. And then I remember there was also a gel study where I think they used an ARV. Yes. So still it didn't work. And right now there is introduction of PrEP, because even previously post exposure prophylaxis was used, but then I think it never landed on many people. I'm not sure, because very less.
Let's just look at the actual studies that you have. Sorry to cut you there, Sister Bohlela. The studies that you mentioned. So we didn't see any real results yielding from those studies, like your vaginal ring studies, like your gel studies. We didn't have the real results that we could be presented to the government who says here is a gel that is actually working in terms of preventing HIV, because there were so many challenges with those studies, whether the participants would not be using whatever the challenges were, but those studies never really yielded the results that we were looking for in terms of HIV prevention. Thank you. I just wanted us to touch on that, to touch on the actual studies that you've heard about, that we've actually seen being done. But moving forward, maybe let us now concentrate on PrEP, which you just touched on right now, because I know that PrEP is also one of the things that we're using now for HIV prevention. So maybe tell us about PrEP. Where are we coming from in terms of PrEP, and where are we now? Like, where is PrEP coming from, and what are the strides that have been taken with regards to pre-exposure prophylaxis in South Africa?
I would say that PrEP is a research initiative, if I may put it like that, because it did not come with the Department of Health. So the research companies have done studies with PrEP, and it yielded some result that we needed. So right now, PrEP is being introduced to the Department of Health. We are giving PrEP to people who feel that they need it, because you know when PrEP was introduced, it was like it focused on those people who are high risk, you know, like the sex workers, those male who are sleeping with other males, those people who are using drugs, who inject themselves with drugs. But right now, anyone who can see that I'm at risk, I'm in danger, maybe the partner is HIV positive and you don't know the viral load, if it's suppressed or not. So you feel that you need PrEP, we give you. And I've seen, especially because I'm working with pregnant women, I sell it to them because
by selling you mean you encourage them.
I encourage them. I teach them PrEP. Yes. No, not
okay.
Yeah. So I tell them about PrEP and how it's going to help them as they are pregnant and when they've delivered, they are breastfeeding, you know, because it's safe in a breastfeeding woman. So we give those people, because you know you can never trust a male person,
any person.
I think PrEP has made an individual to be responsible for their health,
take
to
power
take charge
into their own hands.
Yes,
Yes.
yes. So that's what we are doing right now, and so far the response is very great. It's very beautiful.
So we are coming from an era where PrEP was actually not available at all to the public, you know, to anyone who needed it, because they were at risk of HIV. So we are coming from that era, specifically in terms of Department of Health of South Africa. We are coming from an era where PrEP was actually not available at all, and then it became available to high risk groups like you mentioned. But now it's an era where PrEP is available to basically anyone who feels that they need it. So I think that is a great milestone in terms of HIV prevention. I think that is the greatest milestone that we have seen in the past years, because PrEP has been proven that it actually works. It's actually one of the prevention methods that has really in terms of HIV prevention. So I think that is a really, really big milestone in terms of HIV prevention, from the time where we are coming from to the time that we are right now. So we can say we have something that is finally working, but we still have room for improvement.
Yes, it cannot be limited to PrEP.
Yeah. So what are we hoping? What are our hopes for the future? What are we hoping in terms of prevention, in terms of prophylaxis? What are we hoping for? I'll tell you what I'm hoping for, because I'm working with companies that actually does surveys every now and then. You know, we take PrEP surveys. We ask these young women, what do you think would be the best thing in terms of prevention? What do you think PrEP is the best way? That was an injection that they can take, like, you know, every 3 months. They say if they wish PrEP was not a pill that you could drink every day. So we are hoping for an era where we can actually have something like a vaccine, you know, that you can take and know that you are protected, you know.
Because the challenge with taking pills is adherence.
Yes, definitely.
It's really a challenge. So we really are hoping for something which is far away from pills. So vaccines, is the option. Yes.
And also maybe as well that comes in the form of injections, like monthly injections, 3 monthly injections, you know, things that will make it easier for the people. Thank you so much, Sister Abeshela. I think that was a very good insight that you've given us in terms of the journey that we've traveled as South Africans, especially among the Black community, from the area of HIV reduction, where we could only just use methods of teaching people, up to an era now where we have a product that you can actually take to protect yourself against HIV. So that would be the end of our interview today. Thank you very much for giving us an ear, and thank you very much for this time. And I'll just give my colleague to say a few words in closing.
Thank you very much for this chance, just to portray how are things in South Africa in the health sector. So I hope there are one or two things that you got or you put in your bags from this interview. Thank you very much.
Thank you.
So that was PrEP and HIV. I saw there was a couple of comments. I'm not sure. Apologies. Are there any questions? Not that I will be able to answer them because my field is not HIV. Otherwise, let's move on to the next interview. And this is an interview with Thandeka by Sipopelo Dlamini, who was on the call earlier. And they're going to talk about premature labor in teenagers that fall pregnant in semi-rural areas in northern KwaZulu-Natal.
So, good day, Thandeka, Sister Thandeka Kwala. I hope you're well. Thank you very much for giving us this opportunity to have this brief interview with you. May you kindly introduce yourself and where you are based.
Good day, Mr. Dlamini. I'm Thandeka Kwala, currently working at Northern KZN at King Cetshwayo district under Umhlathuze sub-district, and I also live there. The clinic that I'm working in is in the Northern KZN, in between the borders of Ilembe district and Umkhanyagode district. Thank you.
Okay, that's great. If you may just give us maybe a setting of where the clinic is. So it's a primary healthcare clinic, am I right? And,
yes.
So what is the setting? Is it an urban area? Is it a rural area? Or it's a mix of both?
It's a mix of both. We are calling it a semi-rural area. It's in Port and Fort under Eskawini, formerly called Eskaleni before it was Eskawini. And when you're moving out, just outside Eskawini, there's some semi-rural areas. Then the clinic is at Port and Fort near Smolanyana shops. In case it's at Eskawini, Port and Fort Mall. Yeah, that's all.
Okay, so it is a semi-rural area.
Yes.
Roughly on average, how many clients do you see maybe on a day?
On a daily basis, it varies. When it's busy, we usually see about 200 clients, but when it's not busy, we see about 60 to 100.
Okay. And what is your role there? What is your position in that primary healthcare clinic, Mkhondokaise?
I'm working as an operational manager of Mkhondokaise clinic.
Oh, that's great. So you are the person in charge, basically, of the clinic. That's great. First of all, we appreciate that from you, that we are seeing operational managers now coming to the fore and participating in research. So maybe let's then get on to that topic or that subject, the nursing research, because it's quite rare to find colleagues who are employed by the Department of Health, working in a primary healthcare setting like you, participating in nursing research. Generally speaking, they focus on service delivery. What inspired you to think of the research question that we are going to discuss here today?
Okay, firstly, I started late last year in the clinic. It was December. So I'm a person who likes to research and also study. So when I was in the clinic and I noticed that on the maternal and child, there are so many teenage pregnancies. And on top of that, I noticed that on January, there started to be so many premature labors. Then it triggered my research mind that I should research about it because I'm not sure what is happening in the area. So I want to find out what is happening so that I can help the girls to not have premature labor because it is dangerous to their lives and also to the life of an infant or a baby that is still growing inside. So my main reason for starting this research was to alert young women and girls and teenagers about the dangers of premature labor and also to uplift the adolescents youth-friendly services, because as a Department of Health, we are failing to help the girls with the services. When they come to the facility, they feel that they're discriminated. So if we are then enhancing adolescents youth-friendly services, then the girls will feel welcomed. So that's what triggered me to do this research on the premature labor of teenagers.
Oh, great. You've mentioned so many important things in your response. So I'm interested, before we go back to the research. So you've mentioned something that you refer to as youth-friendly services. Is that a certain component of the care that is rendered in South Africa?
Yes, it's a certain component made specially for the boys and girls aged from 12 years to 24 years. So that they can feel welcomed at the facilities. It is an initiative by the National Department of Health, and it was also adopted by the KZN Provincial Health and also all the districts from KZN. But initially, as you know, that in South Africa, whenever there's a new program that is introduced, it's the nurses also have that fear, not sure what is going to happen, fear of unknown. So they fail to initiate or they fail to start the program. That is why I'm saying it's when I came in, it's like it's dead. So I want to revive it back. That is why I'm more interested in it, because young men and girls will then have more knowledge other than going to the websites and also asking the wrong people. So there's also a website going along with youth-friendly services, which is called UPWise. But then if we are then doing a practical thing with them, they'll also link it with UPWise. But when we are talking with the boys and girls, then they'll associate. And what triggered youth-friendly services was the questions that were asked by our teenagers, and the healthcare workers were not comfortable to do it. Like, why are you dating older men? And then they just roughly said, because nurses also date them, and we also want money. Nurses don't have enough money. So for us to get money, we have to date older people. So it triggers our insights and also how we feel about the teenagers. So if we listen to them more often, then we'll see their problems and we'll understand why are they being involved in drugs, involved with amaplesas and all the other ill heads that they are involved in. Thank you.
Okay, thank you very much. So, and by amaplesas, you mean the syndrome where older men date young girls in South Africa? That phenomenon is called amaplesas. It's like the older man is blessing. That's why it's called amaplesas. It's older men blessing the younger girls with money, with things like phones, mobile phones, and all those things. Okay, now let's get back to the research. What is your research question? What are you going to research about?
Okay, I'm going to research about, firstly, want to know the reasons behind why are they getting premature labor, because it might happen that it's stressor or there's something that they're inducing labor with. So my first questions will be asking those girls and also the community, because I have to involve the community because they are from the community. So I have to ask what is it that they are using to induce a pregnancy, or is it happening spontaneously? And also I have to interview also mothers of these young men, young girls that are falling pregnant and then getting the premature labor, because you might find that the girl is now taking the herbal medication or whatever to be in labor, because the mother is then threatening the child. The child wants to go back to school, but she cannot go back to school because she's still pregnant. So the mother will just say, there's nothing I can do about you, see what you can do. And then the teenager will speak to another teenager, and then the other teenager will say, there's a mother, there's a mother who is Nyanga or Isangoma. Then they can give you herbal medication. Then they take that herbal medication, which is dangerous to the child and even to the mother. And I will also interview professional nurses, which are midwives, because they are the one that see these patients. So I will not interview only. I will also interview the other clinic in the semi-rural areas, like Untuze Clinic, which is in a semi-rural area near Umtunzini, and also interview Siboniso Clinic, which is in the area of Impembeni, also at Eskawini, because they are in the semi-rural areas. Thank you.
Okay, that's great. So you are really going to do a 360-degree interview. Then
yes,
the teenage girls themselves will be part of the research. Their mothers would be part of the research, and healthcare workers as well are going to be participants in your research, so that we get a global view really of what is the cause of the problem.
It's really happening, yes.
Okay, no, that's great. Maybe if I may also ask, can you give us sort of a range in age when we say teenage girls? What's the age? What ages are we talking about? It's between what and what?
Okay, according to my research, the ages that I'm looking from 12 years to 19 years.
So you in your facility, you have already, within the short space of time that you've been there, you said you joined the clinic in December 2020.
December. Yes, 2020.
So in the past 6 months that you've been there, you've already noticed that you've got girls who are even as young as 12 years falling pregnant.
Yes, and even 6 who's a graph 2, which means she's now having 2 children, but she is 16 years. Yes.
Sure, that's really worrying. It also might actually trigger if someone is interested in research, and that is what I was referring to earlier, to say there are always research questions. It's just that we as nurses, we need to be thinking along those lines, because that triggers another question, because family planning in South Africa is freely available at all healthcare facilities. So why are they not using it? That's a different research question altogether. But I'm just saying, for someone who if we are all as colleagues with the other nurses that you work with, they might also just get involved and look at that aspect as well. Now, where are you in your research now? Have you written the proposal? Have you submitted it? Where are you, if you can just give us a picture? Because you've identified the topic or the question, then where are you?
Okay, right now I have submitted my research proposal, and last night my research proposal came back as approved. So my next step, that's in research. So in my planning, I was planning to start on the 1st of June. So I'll have to plan my tools that I'll be using, print everything, the stationery, get the consent forms so that they will consent, because I will not ask them questions if they haven't consent as yet. And also I have to go to a traditional authority, because when we are doing a research at primary healthcare level or at the semi-rural areas, you have to go to the authorities to get a permission, because you cannot research in their area without them knowing. And also I have to get a permission from the Department of Health, which will be my sub-district. And also my sub-district has to forward my other consent form to Provincial Department of Health, so that I'll be able to research freely. So
Oh,
that's why
great. No, that's great. So, and congratulations on your proposal being approved. We are really happy. So you already have a supervisor, and it's all systems go now. It's obtaining approvals, and then the research can. And maybe if you can give us timelines. You said so. The next 2 weeks are going to be working on approvals, and then you'd probably start. When do you think, and how many research participants do you think you'll have in total in your research project? When do you think you will complete the data collection aspect, and then how many participants are going to be in?
Okay, my participants for AMA teenagers, I'm looking at, because I'll be doing 3 facilities, so I'm looking at 5, 5, 5. That will be 15, and also the AMA, it will be 5. It means I'll have 15 girls, 15 mothers, and for AMA midwives, I'll have 2 per facility, so it means I'll have 6. So in total, I have 48.
Is it 36? 36.
36. I'm bad with numbers,
36.
sorry.
I know, that's fine. So you'll have 36 participants. That's quite a huge job, I can tell you, especially if you think about the consenting part, the interviews, and then the data analysis. But all the best. We wish you all the best in your research proposal. And when do you think you'll complete your research proposal?
Ideally, I want to finish by the end of November.
Okay, so you've got between June and November, it's about 6 months for data collection.
6 months, yes.
Okay, the whole research project.
Mm.
No, that's good. No, thank you very much, Sister Kwala. We appreciate having this discussion with you, availing yourself and sharing your research proposal with us, and we wish you all the best going forward. Thank you very much.
Thank you, Mr. Dlamini.
Maybe as we end, may I ask if you think it is important for other nurses, especially in South Africa, who are working in primary healthcare, to emulate your example and also conduct research in their healthcare facilities?
I think it is important for all the nurses that are working in the primary healthcare facilities and also in the hospitals to do research, because we are working on the evidence-based practice. So if we are only relying on the research that was done 20 years ago, then it means we will be using old information while we are in the new era and not that older era of 20 years ago. So it's best for, I would advise most nurses to do research so that we can move with the 4th industrial, 4th IR, because really our world is changing now and again. So if we're not researching, then it means we'll be left in the old era.
No, thank you very much, Sister Mdlecha. We really appreciate Sister Kwana. I keep referring to your other surname. Thank you very much. We really appreciate you having time with you, and we wish you all the best in your research, Sister Kwana. Thank you very much.
Thank you, Mr. Dlamini.
So that is you can administrative nurse. She's actually in charge of the clinic, and she saw a problem which she's now going to do research on. And I think, the more people, as they said, the more nurses who can do that, the better. Welcome, Diane and Terry, and who else is new?
Laurie. Is Laurie new? Or was she been here?
Laurie, no, Laurie has been.
Sharon. Anyway, I think you should be a talk show TV producer, Elise. I think you have this talent for getting people to work so well together in these settings. It's quite remarkable. It's wonderful.
Thank you so much. That's my next career. I've had many careers, so I'll do that as my next career. Have you got any questions or comments before we go? There's one more interview, which is going to be short, and then we would need to take a break because I need to change slides the next slides are on a different PowerPoint presentation.
Could I just ask Elise, I'm sorry to interrupt, how short is short? Because I have a presentation I'm giving elsewhere at 2 o'clock. So I need to know when I need to go. I don't want to interrupt things.
So I've got it as 10 minutes, but it's the time that it's going to take me just to change slides, and it can be 5 minutes. And if the people that's still on the call, if they need a longer break, it's unfortunate that they can't.
Well, we can unmute that. We can ask everyone. Everyone is so nice. I'm sure they're going to be nice when we unmute them. Let's ask
I don't
everyone.
think we will have any.
Well, we could, because we didn't expect it the other day in Wisconsin, and it was quite shocking.
Yeah.
So I'm asking everyone to unmute. So you should be able to click your button to unmute yourself and say hello if you're near your computer or in a place where you can speak. I know sometimes people are working and busy.
Hello.
Hello, everybody.
Hi.
Hello. Morning.
Bye.
And you can put your camera on if you aren't too shy.
No.
But you don't have to. Look at me. I put my camera on and I look like this. No one looks this bad. Hello.
Hi. Hi, everyone.
Hello. Oh, somebody's having a snooze. Claire. Eva.
She's got grapes.
How sweet. How sweet. So you've been asked if you want to have a break. When were you going to offer them a break, Elise?
There's one more presentation that I would like to do, and then I need to change slides. So can we have that presentation? And then I change slides.
And how long is the presentation?
It's going to be 5 or 10 minutes at the most.
So why don't you do that? If everyone's happy,
Yes.
you do. I would suggest you do that. Yeah.
Okay, great.
Okay.
So if everyone can just then unmute or mute yourself.
I can mute them all now. I can't unmute them all easily, but I can mute them easily. Strangely. And
so let me just get those slides.
I've asked you to unmute yourself, Elise, because you're muted too.
Thank you. Okay. So the next company or research organization that we're going to have a look at is the Aurum Institute, which is in the Gauteng province. And that's where Joburg is. Most people know about OR Tambo. That's where you would fly in from overseas. The Aurum Institute was established in 1998. It's in Joburg. It has got staff in the US. It operates in Ghana, Lesotho, and Mozambique. And they do research, but they also they also provide health services. And of course, their vision is to improve health, and their mission is to impact global health through innovation, evidence, implementation, and integration. And I found this this YouTube clip, which I just love, and recently done an interview. They interviewed Tuli, and I'm not going to try to pronounce her name. They interviewed her, and you will get a sense of what she does as a research nurse, as also a bit more about the Aurum Institute.
My name is Tuli Sajaya. I'm a research nurse at Aurum Tembisa Clinic 4. Basically, I'm the person who sees participants when they, as a follow-up for their studies or getting enrolled into the study, do their vital signs where just check their blood pressure, their weights. I provide family planning. I do their HIV counseling, risk reduction counseling, where I engage with them as to how they're going to prevent themselves from infected with HIV. We formulate a plan, and then on the following visit to just see if they were able to achieve that. My nursing career started in 2003, where I started my training as a nurse. It was back in Durban, Addington Hospital. I studied there for 4 years and then left there. And then in 2016 was the first time I was introduced to research, clinical research. With the nurse here, you get to work mostly independently, whereas in the hospital setting, you always would somehow rely on the doctor. Sometimes I work here when the doctor is not on site, but she is reachable by phone, and it's quite achievable, provided I know I can reach her over the phone if I have any problems or I get stuck somewhere. It's quite nice.
So that's a snippet of the Aurum Institute. And let me just be clear, to really do justice to all the research organizations, all the different kinds of research that's done in Africa, I would say we need a week. So apologies to those that we do not showcase here or do not talk about, but so that is the Aurum Institute. Just one thing, I'm not sure if you noticed, where she walked in, the walls were like it was not a smooth wall. Because what most of these research institutes do, it's a university that, like Wits University, has got Aurum as a NGO or as a collaborative unit to do research. And then what they do is they use containers, shipping containers, and they convert the shipping container, like what you just saw. She walked from a shipping container to I suppose I've never been there, but I just wanted you to point that out, that I'm sure she walked from a shipping container that's one part of the office or one part of where they do the research to another part. Welcome, Akona. We're going to take a short break, and unless you've got questions, have anybody got questions or comments?
I'm just astounded by research nurses are amazing. They're flexible, they're adaptable, they can do anything. And to see, when you mentioned the shipping container, and we saw images of lumbar punctures under the tree earlier today in Liz's presentation, and hearing about the young people that nurses are working with, and the research that they're doing, and how they're learning statistics remotely from a mentor in America, it makes me feel like anything is possible, and to make so much out of it, what feels, compared to what we have here. So I don't mean to diminish it, but it's just remarkable to see the strength and the abilities that people have to get the work done under circumstances that I certainly feel embarrassed not to have been aware of in the past. So thank you for opening our eyes and sharing everybody's work in this way. The power of nursing, absolutely. And
Yeah.
you know, in this place and in this way is just really mind-blowing.
Yeah. Well, I can just say thank you, and I'm really grateful that the visits turned out to be virtual visits.
Me too.
Because to have that and to record that and to show it in the future would never have been done. No. Because how can you travel from Nigeria to Ghana to DRC? That's just impossible. So I know COVID is mostly we wish it never happened, but this is the unintentional consequence of that. Yeah. And thank you for hosting these events. Really, thank you.
Well, you're hosting them. I'm supporting them, but you've done an amazing job. I'm going to have to leave before the next chat because I'm giving a presentation. I may come back. I'm not sure how late you're here. I'll have to double check. But you had me on Africa time earlier. I was running around telling my family someone was coming in 10 minutes, and it was an hour and 10 minutes because it was Africa time. So you've taught me a lot today.
Thank you, Fikile. Thank you for joining us, and thank you for your contribution. We will definitely be in contact. You might just be asked to present again because of the awesome work you did. So watch your inbox. There will definitely be an inbox present for you.
Yeah, amazing. Let me unmute. I'm unmuting you, Fikile, so you can speak. You need to click your button now.
Thank you so much, everyone. Thank you, colleagues. I really look forward to whatever will be sent my way. Thank you. Thank you so much.
Great.
Yeah. So, Elise, you're able to let people in and do all that if I go when I go. You're host, so you should be fine. Okay.
Yes. Yes.
Brilliant.
So we're going to take a break so that I can switch slides, open the other slide deck that I've got. And what we're then going to do in the next, after the break, is we're going to take a tour to Ghana, Kenya, South Africa, and Uganda, and look at YouTube clips that I found about research that's done in certain centers. So it's a change from clinical research nurses talking to us versus the voice through the person who's going to talk. So let's come back at let's come back at 10:02. I can't say the hour because everyone's hours is different. So let's be back at 10:02, whatever your hour is. See you soon.
We're just taking a 5-minute break, and we'll be back soon.
I welcome Samantha. We're just on a break. We're going to start at 10:02. Thank you for joining us. There you go. It's 10:02. We're back, and thank you for everyone who joined us. Samantha, Theodora. Would you mind everyone just put into the chat box where you're coming from, because so that we just know. I don't know all of you. That would be great, so that we can just see who you are. Maybe just tell us also who you are, meaning what do you do. So this last section of today, we're going to take a tour to Ghana, Kenya, South Africa, and Uganda, and get a glimpse of what it takes to do research in Africa. I'm going to start off by telling you or introducing you to the Africa Academy of Sciences. They are non-aligned, not-for-profit Pan-Africa organization based in Nairobi, and their vision is to see transformed lives on the African continent. They've got 3 mandates: recognizing excellence, functioning as an advisory or think tank, function, shape Africa's science, technology, and innovation, and then implement the science, technology, and innovation programs. So their focus areas are environmental health, climate change, health and well-being, natural sciences, policy and governance, and social sciences, science and humanities. And in this specific clip that I'm going to show you, they ask the question, why is there a low representation of African countries in clinical trials?
Although the African continent has about 25% disease burden, which is the highest globally, the level of clinical trial investment on the continent remains minimum at about 2%. Africa has the greatest diversity in terms of genetic composition. We have over 3,000 ethnicities, which tells you how diverse we are. Over the decades, a lot of research is conducted off the continent, and we are consumers of the products of research or work done off the continent. And the problem with that, especially for clinical trials, is that there are products that are tested off the continent and then brought here, and all we do is consume them, and we are not sure about their efficacy and safety in our people. The question was, why is it that our sponsors are not willing or do not find Africa a good space for them to conduct their clinical trials? Through various conversations with our key stakeholders, it was clear to us that the clinical trial sites on the continent are not visible to them. They don't know where these sites are. They don't know what capabilities they have in terms of infrastructure and in terms of human capacity. We decided to sit down as all the stakeholders that are involved in this space to figure out what is the best way then to make it possible for our sponsors to identify where these clinical trial sites are. If we can create a community, an online platform that is easy for people, one, to identify where the clinical trial sites are, to find clinical trialists that have the same interest as themselves, and also to provide them with information about our regulatory timelines and ethics and review boards, then it will make it much easier for them to make the decisions to come to the continent. Conducting clinical trials on the continent will allow us to actually do the trials on our own people. It means that if we can be able to conduct clinical trials here, we will have more relevant products pushed forward to the bedside for our people. The drugs will be more relevant, more efficacious, more safe, and will save governments a lot of money, which sometimes they have to spend on what we call adverse effects when these drugs are not tested locally. The African Academy of Sciences, by creating this platform, we would like to change that by increasing the visibility of the sites and the clinical trialists on the continent so that we can increase the investment and change that 2% to something bigger. If we can have 15% of the clinical trials being conducted on the African continent, that would be a great success. The challenge I want to give to all the stakeholders in the clinical trial space is that this platform is for you. My request is that work with us to make sure that it's up to date, that the information on this platform is accurate, because then it will be able to inform all of us in terms of decision making. On top of that, I'm also challenging you to be champions for this platform. Tell people about it, tell your colleagues about it, share the information about the proposed platform, or speak to us at the Academy and we'll be able to give them more information about the proposed platform.
We are going to stay in Kenya, and now we're going to have a look at the IACRN University and the research that they do there. So, of course, this is the hospital, and their vision is to be the best. Can I translate all those words to the best tertiary teaching and referral health facility in sub-Saharan Africa? They have been around for 60 years and they operate in East Africa. And the IACRN University Hospital sets the standard for comprehensive healthcare and modern medical education. And just also to mention, there is a IACRN University Nursing School. They've got 3 campuses, one in Nairobi, Kenya, one in Uganda, and one in Tanzania, in Dar es Salaam. So you will see here what I'm from a state of the art, a clinical trial in this hospital as a response to the COVID pandemic.
When the Chancellor opened the Heart and Cancer Center, his key aspiration was that we would have a research program at AKU Nairobi. We have a clinical studies unit, which is probably the best in the country, as good as any in the US. Roche Pharmaceuticals felt like we could do this clinical trial very efficiently and compliantly. This was the first therapeutic trial in COVID pneumonia in the whole of East Africa. AKU was the premier site to contribute. It means first that a major pharmaceutical company has trust in Kenya to do clinical research. It also means that within Kenya, we as AKU stand out to be a center of excellence that can be depended upon to do this kind of clinical research. Roche Pharmaceuticals chose us because of our capability with the clinical research unit. We have a very strong clinical investigator, Dr. Rina Shah, who's the principal investigator. So the entire team at AKU was premier. The only other site was South Africa. So there were only two sites in Africa, the AKU site in Kenya and the South African site. We enrolled 10 patients. The South African site enrolled 6 patients. So we clearly were leading in enrollment in the entire African continent. The clinical trials involved patients with COVID-19 pneumonia who were on oxygen, so they had to be oxygen dependent. They did not have to be on ventilators. In fact, you could not be on a ventilator. And the objective was to avoid patients getting onto a ventilator, which is a very morbid condition. The study lasts 28 days. That's the observation period. Patients get 1 dose of the study agent or placebo. As I said, 2/3 of the patients receive study agent, 1/3 receive placebo, but everybody receives best practice care. At 28 days, we assess, did patients get worse? Did they get better? Did they get home? Or did they have to go into the ventilator? Those are the endpoints of the trial. So we have clearly the knowledge, the expertise, and the patient populations. And that sets us apart from any other academic center or any other center in East Africa or Sub-Saharan Africa for that matter.
We stay in Kenya, and now we're going to the Kenya Medical Research Institute. And this is a state corporation established in 1979, where the IACRN is a foundation. There's a IACRN Foundation. That's what I'm going to call, from South Africa perspective, is a private organization. So KEMRI is a state organization, a government organization with the mission to improve health and quality of people through research, capacity building, innovation, and service delivery. So the programs are varied by technology, public health, health systems, sexual reproduction, natural products again, and drug development, infectious and parasitic diseases, and NCDs. You will notice that there's a scope for natural product research, because herbs is one of the treating modalities that in South Africa Sangomas use. So researchers are making it their business to also research what's called natural products. So in contrast with what we just saw, which is a hospital-based clinical trial, now we're going to see how KEMRI involves the communities in the clinical trials.
During public health emergencies, it's very important for communities to understand the problem. Because once communities understand the problem, they're able to engage and engage meaningfully. And that engagement helps science to flourish, because then communities support the science.
I'm a pediatrician by training. When we practice medicine by the bedside, you really want to have evidence for what you're doing. When you give a child oxygen, you want to know how much you're giving them, for how long, and when it's okay to stop. You can only make those decisions if you do clinical trials. Before we even do a study, we sometimes engage with the community and get their opinions about what we're going to do. We had a week where, 12 participants were due to come for a visit, and then only a fraction turned up. Immediately that's alarm bells, because that hadn't been happening for the months prior to us starting. So we went to the community liaison group and said, look, there's a bit of a problem here, people are not turning up. We've spoken to our field workers, and they think then they're a little bit worried about their babies having blood taken.
Mimi ni mmoja wale walikuwa wanaamini kwamba KEMRI ni watu wabaya sana, kutokana na matukio ambayo labda yalitokea huko nyuma. Nimeishi nikiamini hivyo. Wengi husema ni kingi, wanasema amekuja mtu wa KEMRI akamtoa mtoto wangu damu chupa tele. Sasa unaona ile chupa, akija akiona ile damu anaona chupa imejaa.
We went through a whole list of activities about how do we actually improve the experience of taking part in that study for the participants. How do we make it a more positive experience? How do we reassure them that everything we're doing is okay? So we changed what we were doing. We changed how we were passing on the message by demonstrating using syringes, exactly how much blood we were going to take, explaining and reiterating how safe it was and where that evidence came from.
Lakini kwa hii nafasi niliyopata kwenda KEMRI ndo nilifundishwa na nikafahamu kumbe ile chupa inapokuja kuchukuliwa ile damu kwa kuna liquid iko pale ndani ambayo inaitwa blood culture. Kwa hivyo mwisho yote inakuwa red na mtu anaona inaweza kuwa damu kidogo tu, lakini mtu anaona damu imejaa chupa tele. Sasa watu wanakuwa na taswishi hiyo.
Based on just one day of 10 people not turning up. A whole set of activities were set up where we went out to the community again and started having barazas and speaking to community members and representatives about what we're doing and trying to get from them what their concerns were and what might be leading them not to turn up.
Manake wanatusikiza kweli, tunayafundishwa tukiyapeleka, lakini wanatamani angalau siku moja tutembee na hawa wanatafiti nyumba kwa nyumba, wakazidi kuwaelimisha na wajue kweli sisi nasi ile huduma wanatupatia, je, tunaifikisha ama tuifikisha.
The decisions that we're making are because of direct feedback of what we see from our participants within the community. It affects us every single day. Clinical trials really fits in with our mission in terms of we want to conduct studies that are immediately translatable, that change what we do at the bedside when we're looking after children or within the communities when we have unwell children.
So I'm going to stop here. Or have you got any questions or comments or that you want us to talk about before we go to the next country? No. Then we hop to the next country.
If you do.
And that is back in South Africa. So this morning I spoke about the Desmond Tutu Foundation and the work that they do in the communities. And this is specifically work that they do in Cape Town, in a it's not even a township, it's a shack dwelling called Crossroads. you will see that although this is what the houses look like, don't think, but this is what it looks like from the outside. It's the same what it looks like in the inside. You know, a couple of years ago, I drove through Crossroads on my way to a clinic to go and do some research at the clinic. And on my way there, in the road, it was a shack built on the sidewalk. And out comes a woman dressed in the clothes that one of our banks called Absa Bank. Our banks have got certain clothes that they wear. And here comes out a woman. If I didn't see that, and I would have gone into the bank and saw the woman behind the teller counter or wherever she worked, I would have thought, oh, she's living in a building, you know, a brick building, etc., etc. So although it might look like this from the outside, it is, I've been in some of these, what we call shacks, and it's just amazing what people have done on the inside of the shack. I also just want to mention, this picture might be a bit small. You can see here, it says Tutu Tester. Well, maybe you can't see it, but just trust me, it says Tutu Tester. So because the Desmond Tutu Foundation and the Desmond Tutu HIV Center focuses on HIV as their research focus, they developed mobile clinics, and it's called it's called the Tutu Tester. So they would park in the community where they've got access, because here you can see there's no access, you can only walk there. So where there's access, they would park there to make it easy for the community to go and get themselves HIV tested. So this clip is about the clinic that the Desmond Tutu Foundation and the Cape Town HIV, Desmond Tutu HIV Center established inside of the community. You can see, here's the car, here's the people walking in the road. This is a typical taxi. We call it a taxi to transport people. I'm not sure whether this is a building. I almost doubted whether they built this building newly or whether they bought a building and just renovated it to this to function as a clinic.
Welcome today to the Emma Vundleni Prevention Centre here in the heart of Crossroads. This community is one of the hardest hit in terms of HIV infection and tuberculosis in the metro of Cape Town. Today we are here because we're launching the HIV Vaccine Trials Network 702 clinical trial. Why don't we go inside and have a look at the clinic? And this is our first station, a very important one where we welcome our participants, and Pam is here always to say hi and make sure we have the right participant on the right day. And to do that, we use a biometric fingerprint system which identifies participants. And like any part of research, it's very important we have a good relationship with the people from the community. Moving then to our second station here, this is about counselling and making sure that people really understand the research that they're getting involved in. So this is the station where informed consent processes are undertaken. People can ask questions and really get informed about what they're doing. It's also the place where we do HIV risk reduction counselling. And that also is really important. A trained counsellor works with participants to make sure that they fully understand ways that they can apply to their own lives to reduce their risk. The next stations are clinical. Let's go have a look. So this is our small on-site laboratory, and we do just the testing that we need to do to make sure our participants are healthy. That'll be HIV testing, pregnancy, STI testing, and the samples are obtained from this section here. So our nurses are key members of the team who make sure that participants are free of disease and screen them for hypertension and other diseases that they may in fact not even know they have. Really very critical in a centre like this that we safeguard participants' health. So the next station is really where the vaccine itself is prepared. Let's go and have a look at that. So the pharmacy is a controlled environment. It's very important that products are kept at temperatures that suit their best action. And this is a hood where we prepare vaccines. Again, sterility absolutely key to the maintenance of the vaccine products. The pharmacy itself is a very important part of the procedure because randomization occurs here. So we have trained individuals who not only know how to prepare vaccine, but they also know, in many cases, how to administer it and also what the randomization process is.
My apologies, my finger slipped.
Reduction counselling. Another hood
I'm so
where
sorry.
we do the maintenance part of the procedure because randomization occurs here. So we have trained individuals who not only know how to prepare vaccine, but they also know, in many cases, how to administer it and also what the randomization process is. So this is our last station, and it's an important one. This is where the clinician makes sure that our participant is ready and correctly prepped for the vaccine, and the vaccine is actually administered here in the clinical room. This is where the vaccine is administered, and we ask participants to stay a little bit afterwards just to make sure that there are no side effects. At the end of this, participants are free to receive their compensation for their time and effort. They're given their next appointment and they're given any other instructions that they might need. We hope that they feel like they've really had a worthwhile time with us, that they've been able to give back to society, and of course we're very grateful for everything that they do for us and the research endeavour. I hope you've enjoyed our tour, and we hope we'll see you again here sometime. Bye-bye.
We're going to stay in Cape Town, and now we're going to the University of Stellenbosch. So what you just saw was a collaboration or a research done by the University of Cape Town. Now we're at the University of Stellenbosch, which you could see is a bit further from the Table Mountain. UCT is about here, and the medical faculty is about there. So Tygerberg Hospital and the University of Stellenbosch, which is just off here. So they're close to, next to each other, like UCT, the hospital and some of the research centers at UCT are also close to each other. So Tygerberg Hospital is the second or another tertiary hospital in Cape Town. Groote Schuur is the other one. And here we find the Threat Research Unit, which was established in 1998. It's situated in the hospital, but it was started by, as you would see in the clip, by a professor who is part of the Faculty of Health Sciences at the University of Stellenbosch. And important to note that they conduct pharmaceutical-sponsored contract research, meaning TRED is a private company other than Desmond Tutu that gets the funding through the Desmond Tutu Foundation. This is pharmaceutical-sponsored contract clinical research, it depends on how you look at it. The research is reviewed by the ethical committee of the University of Stellenbosch. And of course, they do predominantly, only cardiology related research. So they committed to advance responsible ethical treatment of human subjects. And this is a brand new clip that I luckily found about the unit.
Founded in 1998, TRED Research is based in Tygerberg Hospital and affiliated with the Division of Cardiology. Managed by Professor Leslie Burgess, we conduct pharmaceutically sponsored contract clinical research in most therapeutic areas by collaborating with and offering tailored trial support solutions to academic departments within the hospital. The feeder area into Tygerberg Hospital is vast, and TRED prides itself in exceeding study recruitment targets. We have a dedicated team that recruits from within the hospital and health facilities in the surrounding area, a well-established referral network, and an extensive patient database. At TRED, it is our mission to protect the rights, welfare, and privacy of people who choose to participate in research. In June 2016, we became the first research organization in Africa to be awarded accreditation by the Association for the Accreditation of Human Research Protection Programs, joining an elite group of only 231 research institutions throughout the world to have achieved such accreditation merit. The trial unit is well established and is set up to conduct reliable research, including site SOPs that incorporates GCP principles, frequently calibrated study equipment, and full emergency trolley. At TRED, we pride ourselves in conducting quality research with the support of our internal QC team. The site has undergone 3 FDA inspections with no actions indicated outcomes, inspections by SAPRA, and numerous sponsor audits. We believe in continuous training and investing in the professional development and skills of our team. We also believe in advancing the clinical research industry in South Africa by providing training and on-the-job exposure to inexperienced individuals that are interested in research. Many of our staff members have moved on from TRED to sponsor companies and CROs. Professor Burgess and our team have been widely published, especially on research methodologies. In this way, we aim to improve the knowledge base of research processes and hopefully the advancement of research practices. Caring for our community and giving back is central to our value system. TRED has supported several causes and organizations and continues to conduct our work in the most sustainable, environmentally friendly way while uplifting our community. COVID-19 has provided the research community with a unique opportunity to educate the public about the life-saving work of science and medical research. TRED Research has risen to this challenge and grown as a company during this time. Our safety protocols have been adapted to protect our staff and trial participants, while facing the front line head-on by getting involved in COVID-19 treatment and prevention trials.
So that is what I would call state of the art. I'm now going to, well, before I'm going to take you to the next country, which is Uganda, let me just ask whether you've got any questions or something that you want to discuss. I see I have to love the community engagement process. Terry, you will see that now. You will see a total different setup in Ghana. Sorry, this one is Uganda. And the contrast between what you just saw, even with the HIV Desmond Tutu in the community where it's in not so good circumstances, and the contrast with what is happening or what they do in Uganda. So I take it nobody has got questions. If you've got any question, just add it to the chat box. Otherwise, I'll take you to Uganda. So Uganda is in East Africa. It's got a population of, in 2019, of just over 44 million. They might now be 45 million people. And it's known for its snow-capped mountains, Lake Victoria, wildlife, and they even have got a gorilla sanctuary. That, I would say, is Lake Victoria, and a bit about how they live in Uganda, and as well as with the bigger towns. So, pediatric infection point of care, a clinical trial that was done in Uganda.
PIPOC is a research study in which we are investigating children who come in with symptoms and signs of infections in their coverings of their brains, what we call meningitis. So we are testing out our tools and developing tools to make a diagnosis of meningitis very quickly and very close to the patient, so that we are able to pick up whatever organisms are causing the disease, and then we are able to target and treat them better. This hospital is a good place for the study because it serves a region of southwestern and western Uganda, and actually also gets children from neighboring countries, Tanzania, Rwanda, Congo. We have a basic infrastructure for conducting studies. We have a team that is competent to do these procedures that we need to do, lumbar punctures, blood cultures. We have a basic laboratory structure, but also an advanced laboratory structure that is provided by Epicenter Research Laboratory. But also we have the numbers of patients. A lot of patients are coming in, and these are the patients we are looking for. So this definitely provides us the best environment to do this study. Every day we probably are seeing about a child, 1 or 2 children suspected to have meningitis. But when we test them, as I said, the tests are not as sensitive to confirm with everyone. But on average, every day we have a child, sometimes 2 children, who meet the definition for meningitis according to the study. When a child comes to hospital, they enter into our ward through the entrance that you can see in the background. and they get quickly assessed by the admission team that allows us to identify whether they have any symptom or sign that could be meningitis. And then once they know, the study doctors and nurses are present as well all the time, and they quickly then evaluate if the child fits into the study. And then we consent the parents, and once they consent and agree to take part in the study, we take the history, we examine the child, and we take samples, study samples from the patient. And then we send these samples to the laboratory, which is in the neighborhood, very close by, at Epicenter and Barrow Research Base. And we quickly are able to return results, and then those results are used to manage the patient by the whole clinical team in the ward. And then we monitor the child constantly thereafter. We participate in giving the child treatment. We monitor response to treatment. And on day 3 or the 3rd day after admission, we take another sample, which is helpful for us to understand the kind of proteins and how they change during the course of admission. Now, the patient continues to get treatment until discharge. Usually, children with suspected meningitis the team that is in the ward that cares for these patients to make sure that they recover fully for discharge.
Here at Epicenter, for the PIPOC project, we work together with the university and hospital, and we also work with the Karolinska Institute and Science for Life Laboratory from Stockholm. For the PIPOC project, Epicenter does all the laboratory work. So the technician receives the samples at that bench, then they will distribute the samples to where they are supposed to go. So he'll leave the ones that are to be worked on in this area, then he will transfer the ones that need bacteriology work to the microbiology lab. Then this other side now, we'll do the HIV testing on the blood. We'll also do the malaria rapid diagnostic test. If it's positive, we go ahead and do the blood smear. We do the chemistry analysis and the hematology analysis. Then whatever remains, we biobank it.
Right now, in this study, we are using something called a filmary, which is a PCR-based technique that diagnoses infections quickly, but that has not been available. It has only come because of this study. Now, otherwise, the fastest way to diagnose and confirm meningitis is with the culture of the fluid around the meninges. Now, that takes about 4 to 5 days. Within 4 to 5 days, or even a week sometimes, most children with meningitis, if it's not well treated, they will have died. So we do not, as we speak, have a test that will fit the purpose for giving us a diagnosis within 1 hour or 2 hours so that we can make very important decisions. We are hoping that with the data we collect in this study, we should then be able to develop tools that will be applicable right on the bedside.
We pride in this kind of collaboration because it is at the heart of the future of medicine for our people in low-income settings. So if we can have a point of care diagnosis.
Every time I add people, let me just, my apologies.
Care diagnostic system that can be run even in a remote setting, which is what the PIPOC team is working towards. Then I know so many children will be saved. Because meningitis is manageable. It can be cured if we can find out the etiology and treat in time.
So thank you for those who joined us, and welcome. I do apologize for the interruptions. As soon as I admit somebody else to the room, something happened. And I also want to apologize for my scatological language. I'm sure you heard that. Apologies for that. It was my frustration speaking, if I can have a reason for using that word. Are there any questions or comments? Please write it in the chat box, or I can unmute yourself. I can unmute you if you've got any comments that you want to add. So just to all the clips, all the YouTube clips that I've showed you up to now are 2020 or 2021. So these are research. This is not old work that's been, previous, long time ago. This is recent work that's been done. And I wanted to show you the contrast between, I'm going to call it state-of-the-art research and not research, but research conditions. And then what, like you've just seen in Uganda, where even with all those partners, the partners make the work happen, and the community who's wanting to have a point of care diagnostic test make it happen, because they know it will make a difference for them in the future. Hi Mina from New York. Sipopelo joined us from South Africa. Samantha is there from Australia. Akona is from Durban. Welcome, Akona. We've got 2 more countries and centers to visit, and then we wrap it up. So I'm now going to share with you what is happening in Ghana. So before I share that, just in the clip, and before I talk about Ghana, this is a video clip of research that's been done in the Ebola era in 2014. But I thought it's to show that, because just to show what happens if the country, the community, like actually with us now with COVID, had to respond immediately. So Ghana is in West Africa. We've just been to Uganda in East Africa. Ghana is in West Africa with a population in 2019 of just over 30 million. They might be 31 million now. And you know about Accra, the town where I suppose most people fly into when you fly to Ghana. And some of the housing, it looks like a housing area. And I suppose I didn't check when I downloaded this picture. I do think this could be Accra. So this is an institute that you will get the history, and they speak specifically about the Ebola outbreak.
September 2014. Following the outbreak of Ebola virus in the West African sub-region, a suspected sample is being rushed to Ghana's Noguchi Memorial Institute for testing. the sample is taken to a highly secure lab called the P3 lab. The only one of 2 labs in the West African sub-region, sophisticated and equipped to handle this level of containment.
Institute. It's named after Japanese scientist Dr. Hideo Noguchi, and the reason was that he was actually working here in Ghana. He had his medical education in Japan and then joined Rockefeller Foundation in the US, and in 1927 or so he was sent down to Ghana, late 1927, early 1928, so then Gold Coast, to come and help a team who were investigating the cause of yellow fever. And unfortunately he died whilst doing that work in Accra. It was opened in 1979 by then President Hilary Mann, with the whole mandate of researching into infectious diseases of public health importance in the country and in the sub-region. The current typical one being the Ebola threat, which is around the sub-region. So we're able to do that testing. When H1N1 came, we're also the ones who were doing the testing.
Two of my colleagues who are coming to work or process the sample that is suspected to be a viral hemorrhagic fever. They will have to open the box within the biosafety cabinet. So they will open it and they will take the sample out. They will spin the sample, it's blood sample. They have to spin it to separate the cells from the cell-free medium. What we need is a cell-free medium for the work. So after that, they will then aliquot the cell-free medium and use it for work. And they will discard the cells, the one that has been separated. They will discard it. But they don't just discard it, they have an autoclave bag, they put it in, and they will autoclave it after that.
We've done quite a lot in the area of health research, supporting the country's activities and also the sub-region. One of the things which is ongoing now is that we the sub-regional center for polio eradication. So we will test for all the polio viruses or suspected cases of polio viruses from Ghana, Togo, and Benin. Not only the country, but in the
September 2014.
So I forgot that video just ends abruptly. Thank you for Samantha for joining us. I was about to look at what time Melbourne, the time in Melbourne is definitely you are nighttime there. And as you say, it's bedtime. So thank you so much for joining us. So that is Ghana. And let me just see if I can allow this person in. So the last, I thought, let me bring you back to South Africa. Again, a rural area, to see the difference between what you just saw in Ghana, what you just saw in Uganda. And just to make it clear, I might just be showing you the science and the lab, but behind all of that, behind this, I call it behind the scenes. Behind the scenes, there are people, and those can only be nurses in my mind, taking consent, taking the blood samples, speaking to people, the participants, being advocates, talking to them about their fears, like you heard in Kemri when they had to talk to the community. So behind all of this are clinical research nurses. Where we're going next, as I said, is back to South Africa, where we're going to go
Following the out
to Limpopo, which is the furthest north province in South Africa. We've got 9 provinces. We've been in the Western Cape this morning. We've been in Gauteng, and now we're in Limpopo. So the poorest province in South Africa is the Eastern Cape. And if I, depending on the year that I trusted Dr. Google to tell me, the Limpopo province is either the second poorest or the third poorest community or province in South Africa. It is beautiful. It is really worthwhile driving the mountains. This is Blyderrivier Canyon. So it is absolutely beautiful. And here is a village, a rural village. And this is where what I'm going to show you happens. There is a company called Glovo Care Group. Clearly, this is a private company because in an area like this rural area, it will be governmental health service providers. So the Glovo Group is a private company. They serve about 150,000 people, and they started a Glovo Research Department to create value for the community and to contribute to the greater good of the society. So I'm going to take you to what it looks like, and again, in one of our poorest provinces, the state of the art that was created there.
Glovo Research Center is a part of Glovo Care Group, an NGO in Limpopo, South Africa. In the middle of a township, an ultra-modern infrastructure has been set up to facilitate top-notch research, educating and employing as many as possible local employees. It has its own research laboratory with access to all instrumentation necessary. It is equipped with a molecular laboratory performing PCRs for COVID and HIV diagnostics, but is also enabled to perform sequencing and contributes to the virus variant studies, which are so important at this stage. Glovo Research Center has its own sample and vaccine storage department with 11 -84 and 1 -135 degrees Celsius freezers.
An important component of our research approach is developing interdisciplinary collaborations both domestically and internationally. And this provides a unique opportunity to bridge the gap between developed and low and middle income countries by expanding our access to cutting-edge techniques and greatly enhancing our research capacity, but also building local capacity through knowledge transfer.
The Research Center has access to the clinic with proper diagnostics, digital X-ray facilities and ultrasound, and it's a very, very family-friendly facility.
Since the COVID-19 pandemic, clinical trials were conducted throughout the world towards a common goal of finding the vaccine that can be used in the prevention of COVID-19 to curb the spread of the virus. An example being an ensemble study which we looked into the J&J vaccine that was used. We at the St. Glovo Research Center, we enrolled 602 participants into the study alone. Up to so far, we have managed to vaccinate more than 20,000 healthcare workers in Limpopo province.
The clinic has its own pharmacy, a proper pharmacy which is well stocked, but also provides a research pharmacy. In the research pharmacy, we are enabled to participate on double-blinded and randomized research whereby investigational products very confidentially can be prepared and managed. The backbone of each and every self-respecting research center is of course its data and data management. Reliable data is incredibly important.
Since my arrival in 2018, the Ndlovu Research Center expanded tremendously into a state-of-the-art facility. Our key success is attributed to our infrastructure, access to data, and participants. Ndlovu Research Center managed to attract scientists and researchers from all over the world and empowered local employees to participate in research. Ndlovu Research Center will expand on clinical trials and academic studies, providing evidence-based outcomes, published in international peer-reviewed journals, and this will influence improvement of policies and guidelines and assist turning the tide on diseases like HIV, TB, COVID, and other public health threats.
You might remember that song because if you follow American Got Talent, America Got Talent, because the Ndlovu choir that participated in the AGT, that's them that sang, and they are based in this community. So you might know about their history, but what I want you to have a look at is the prevention of, I'm just going to allow the prevention or promotion of hand washing. Aye. And that brings me to the end of the day. And I want to thank you for being here, for listening, for engaging. And I'm going to stop the video or the share. Have you got any questions or any comments? I will unmute you if you can't unmute yourself. And so if there's no, and I'm not sure whether you're typing or whether I should wait for a comment or not, just give me a nod, yes or no. Thank you so much. Thank you very much for attending. What I'm going to leave us with is a song called We Are the World. And when I got, in preparing for this presentation and for this day, I was just present to, although this We Are the World was in 2010 when Haiti happened, a couple of artists came together and they molded a bit to fit into the situation of Haiti at the moment. But when I listen to it, it's for me as if we are the world. And that's the tour that we're taking, that we're busy taking around the world in terms of International Association of Clinical Research Nurses, celebrating nurses and celebrating clinical research nurses. So I invite you to listen to the words and to, as a thank you from me, and to be really clear that you are part of the world. We are part of the world. Thank you for being here. I'm going to stop sharing and get the video going. And the words going. So apologies for the ads.
There comes a time when we heed a certain call, when the world must come together as one. There are people dying.
Oh, when it's time to lend a hand to life, the greatest gift of all.
We can't go on pretending day by day
that someone somehow will soon make a change.
We are all a part of God's great big family, and it's true, you know, love is all we need. We are the ones, we are the children, we are the ones who make a brighter day, so let's start giving. There's a choice we're making, we're saving our own lives. It's true, we'll make a better day, just you and me. Well, set up your heart, oh, so they know that someone cares.
So their cries for help will not be in vain.
We can't let them suffer. No, we cannot turn away.
Right now, they need a helping hand. No someone lie. We are the children. We are the ones who make a brighter day. So let's start giving.
Oh, there's a choice we're making. We're saving our own lives.
It's true, we make a better day, just you and me.
When you're down and out, and there seems no hope at all.
But if you just believe, there's no way we can fall.
Well, let us realize, oh, that change can only come when we stand together as one. We are the world. We are the world. We are the children. We are the children. We are the ones who make a brighter day. So let's start giving.
Gotta start giving.
There's a choice we're making. We're saving our own lives.
God, it's true, we make a better day, just you and me.
We are the world.
We are the world. We are the children.
For the children. We are the ones who make a better day.
So let's start giving.
There's a choice we're making. We're saving our own lives. It's true, we make a better day, just you and me. We are the world.
We are the children. Let's start giving.
There's a choice we're making. We're saving our own lives. It's true, we make a better day, just you and me.
Come on now, let me hear you.
there's no water, what's your will to live? We'll amplify the love and watch it multiply. Feeling like the world's end, we can make the world win. Like Katrina, Africa, Indonesia, and now Haiti needs us. They need us, they need us.
We are the children.
I just got emotional. There's so many things happening in the world, and well, this was just applicable for me to end this day. And I want to say again, thank you so much for everyone who joined us. Much appreciated, and blessings on the rest of your day. You're welcome, Terry. Yes, we are clinical research nurses are the world.
But that won't stop my loving you. How could you leave without regret? Love me with all of your heart, that's all I want, love. Love me with all of your heart, or not at all. Just promise me this, that you'll give me all your kisses, every winter, every summer, every fall. When we are far apart, or when you're near me, love me with all of your heart, as I love you. Don't promise me this, that you'll give me all your kisses every